Okay, well, while we load up one more talk, let me introduce Kate Harrington Smith from University of Colorado.
Why, Mr. Schussler, thank you.
And actually, I'm very pleased because the next three talks are all pediatrics, so it's really good. He's talking this morning. Lily's gonna talk about pediatrics. Anyway, and so, Kate's going to talk about measurements in preschool children, and then this will be followed by Laura, who will be joining us virtually. We'll also be talking about a program looking at oscillometry in preschool children. All right, so Kate, please take it away.
Okay, great. All right, thank you so much for this opportunity to speak to you today. I'm excited to share some of the work my colleagues and I are doing to use oscillometry to characterize lung function in toddlers and preschool age children who have had multiple wheezing or asthma exacerbations and are at high risk of developing persistent asthma later in life. And so our team at the University of Colorado Anschutz Medical Campus is currently conducting a longitudinal cohort study called Windows, where we have recruited 119 children with recurrent wheezing episodes from our Children's Hospital Colorado Denver area patient population. These children were enrolled in 2022 and 2023 at ages 18 months to 3 years old, and they all had at least 3 prior acute wheezing episodes. And then additionally, because the study is funded through the Childhood Asthma in Urban Settings or CAUSE network that targets children from low-income settings, our study participants also have to have had public health insurance or live in a census tract with more than 10% of families having incomes below the federal poverty line. And so we are following these children over 4 years with 5 annual visits where we are tracking clinical traits, lung function, and airway transcriptome trajectories to determine associations with a diagnosis of persistent asthma at age 6. And so at each of these research visits, we are obtaining pre and post bronchodilator oscillometry with the TremorFlow 7 to 41 hertz waveform to measure lung function. And currently within our study, we're just finishing up our 2nd annual visits and we started the 3rd. So our cohort of 119 children is 61% male and 39% female. And at the time of enrollment, 50% were in the older age range of 2.5 to 3 years, with 23% 1.5 to 2 years old and 27% 2 to 2.5 years old. And we do have an ethnically diverse population with representation from all the commonly reported racial categories, with 45% of caregivers identifying their children as Hispanic or Latino, 11 of which were Spanish-speaking only families, 9% identified as Black, 27% identified as white, and 19% identified as multi-ethnic or another racial background. So as would be expected based on our inclusion criteria, the burden of systemic steroid courses and hospital visits for wheezing attacks is high in our cohort of toddlers. 65% of children had already previously received at least 2 prior courses of systemic steroids. 60% have visited the emergency department at least 3 or more times, and 50% had 2 or more overnight hospital stays. And so parents are given the test for respiratory and asthma control in kids survey, which contains 5 questions about how often their child has been bothered by breathing problems during the day and at night in the past 4 weeks, treatment with rescue inhalers in the past 3 months, and treatment with oral corticosteroids in the past year. So at the enrollment visit, 61% of children had a score less than 80, which indicates that their breathing problems were not under control, and the median tract score was 75. So in addition, some background, 76% have used inhaled corticosteroids, either currently or in the past, for treatment. And then 81% said that their child's doctor has already given them a diagnosis of asthma. So to obtain oscillometry in our window study visits, we generally try to obtain 4 to 8 measurements in a testing session, of which the 2 to 3 repeatable and acceptable trials are averaged together. These tests included, and the average are selected for the best repeatability in both resistance and reactance across all frequencies, with an R7 coefficient of variation less than 15%. And so we do accept 2. It's really, really challenging to get oscillometry in 2-year-olds. So sometimes that's all we can get. And so our acceptable measurements have steady volume and flow over the 20 seconds with at least 3 complete artifact-free breaths. And the standard TremorFlow software, we use that algorithm to exclude the breaths and data without artifacts. And we also exclude measurements with paradoxical curve bends and resistance and reactance, which I found that this typically occurs when the child is breathing at an abnormally high respiratory rate or panting into the device. So we use the Ducharme 2022 reference equations to generate the z-scores to compare our results to a healthy population. So far in our ongoing study, we've had 221 clinical research visits with our 119 participants. Oscillometry was attempted at 150 or 68% of these visits. Generally, we did not attempt when the kid is very uncooperative or they just refuse. Among these attempts, pre-bronchodilator oscillometry was successful at 109 visits, and we were able to obtain acceptable pre and post oscillometry at 87 of the visits. So breaking this down by the child's age, this plot shows the percentages of success in green, attempts in blue, and no attempts in orange, and the total number of visits, and the lighter shades are female, and lighter shades are female and darker are male. And you can see that rates improve dramatically with age, with most 3 and 4-year-olds having successful tests, and also a good number of 2-year-olds were able to do it and a couple of 1-year-olds. So among our individual participants, 71 have done oscillometry at least 1 visit, some multiple times, and 48 have yet to succeed with this, but the primary reason is likely attributed to age, where most of the children with unsuccessful were younger, around 1 or the younger 2-year-olds, while the successful tests are 2 to 4. But there's no difference between males and females, between successful and unsuccessful, and this mirrors our overall demographic of 60% male and 40% female. So now to get into the oscillometry results, I'm going to show the results from the first successful test for 71 participants with acceptable results. So in our cohort of wheezy preschoolers, the median airway resistance is greater or worse than the mean airway resistance measured in the reference population of healthy children at all 10 frequencies. And this violin plot showing the median z-scores for resistance at each frequency, the white circles with the 25th and 75th percentiles, with the distribution of data points. So here we found a median z-score for resistance at 7 Hertz was 1.27, with 39% of participants having an abnormal R7 z-score greater than a 1.645. And the proportion of children with abnormal resistance at the higher frequencies was lower, ranging from 20 to 30% across this spectrum. For airway reactance, was also more negative or worse than the reference population mean, 7, 11, 13, 17, and 19 Hertz, with 44 to 48% of children having abnormal reactance z-scores less than 1.645. And the median X7 Z-score here is negative 1.37, and 46% had an abnormal AX. Considering the derived area of reactance metric, AX 54% actually had higher or more abnormal AX compared to the reference, with a median Z-score of 1.79. And so collectively, our Wheezy preschoolers have patterns of increased airway obstruction and lung stiffness compared to the reference set that we were using. We've, their first attempts, 58 individuals have had acceptable pre and post bronchodilator tests with albuterol. We take the post at 15 minutes after the last puff of albuterol, and both resistance and reactance improved after bronchodilator, with median post C scores dropping to the reference population mean. And all participants had, except 3, decreased in both R7 and 8X, with the median absolute decrease in R7 Z-score 1.54, and median decrease in AX was a little larger at 1.94. So the plot on the left shows the mean raw values with 95% confidence intervals, shading for RNX across the frequencies, pre-bronchodilator in red and post-bronchodilator in blue. And this corresponds to a median to 23% post-bronchodilator decrease in R7 and a median 47% decrease in AX. And only 4 participants actually met, I think, what are the currently suggested cutoffs for response of 40% in R7 and 80% in AX. So overall, 56% of children had abnormal oscillometry. At least one abnormal oscillometry metric at baseline. Well, 44% were within the normal range based on the Ducharme reference equations. And so breaking this down, 36% had abnormal resistance and reactance, 17% had only abnormal reactance, and only 3% had abnormal resistance. So recalling the track score I talked about a minute ago, we find that measurements of normal or abnormal lung function determined by oscillometry were not related to the level of breathing problem control reported by their parents. This is important to note because typical clinical assessments in this preschool age population really rely on parent-reported symptoms. We also, the first talk this morning was about poor perceivers in adults. So not a lot to go on there. So utilizing more objective measures of lung function with oscillometry can help refine the treatment plans that our pulmonologists give to these wheezy toddlers. So in summary, 60% of children in Windows have successful oscillometry so far, and the success rates are improving with age. Resistance and reactance are worse, showing greater airway obstruction and stiffer lungs when compared to published healthy reference population data. Resistance and reactance decrease to the expected population mean in response to bronchodilator, but percent change does not meet the current suggested definition of a positive response. And oscillometry, an objective measure of lung function, does not really align with the parent-reported measures that we can obtain for respiratory control. So, conclusion, oscillometry is feasible as early as age 2 and perhaps a couple 1-year-olds, and provides an objective measure of lung function during the preschool years that can be used to understand the early life lung function deficits and track responses to treatments. So I'd like to acknowledge all the hard work by our team. We have a huge team for this study, and our research coordinators have really been amazing at getting little uncooperative children to do this test. Can go on for hours about all the techniques they use, but they've been really amazing, and we really appreciate our participants and families.
Or even stand up. Go ahead, Sue.
I was involved with the camp study and we were under kids as young as 5 because we're using spirometry as the primary output. We always talked about the fact that we probably younger. And then we actually explored using oscillometry in kids when I was at National Junior. And I had very little trouble getting 2-year-olds to do it, the few that I had access to. So I'm wondering if you have any insight to why the 1-year-olds I can understand, but the 2-year-olds didn't do a little bit better with it. So you're still only getting about 60% of them. What do the coordinators tell you? Some of the major issues. I mean, are the kids just freaked out? Are the parents freaking the kids out?
Yeah, I think there's a lot of because these kids have been hospitalized multiple times in the past, there's some fear of medical professionals and devices. So that's one thing I've heard. Another, the different developmental stages, and sometimes some family chaos, like when the parents bring like all 6 siblings into the visit room, there's a lot of distraction, like it's it can be kind of challenging in that way, but we try to work with the families, and I mean they get the kids to watch a video. Apparently Cars is like a really popular one that they like to watch during oscillometry. They watch the video and just try to get them to.
You do the oscillometry at the beginning of the visit or at the end?
We do the pretty early on, and we try to get, and then they do a few other things and then play a little bit and they get albuterol and do it again. And we save our like invasive procedures like blood draws and nasal swabs to the end, because after that would be.
See, we used to pay the kids, so that worked. We had dollars that they turned in for toys.
Yeah.
5-year-old understand, 2-year-old.
No.
They don't. They don't know about that.
Would there be any added value to adding to the graphic a cartoon? Some of the spirometers have dragons blowing out, trying to cook marshmallows with their breath to get the kids to blow. Would something integrated into the oscillometry software like that be useful?
Yeah, I think that would be really helpful. And I've actually had a couple of coordinators who do meditation or use meditation apps. Like there's one, I think that's like a flower that goes in and out, and you could kind of program that to be an optimal frequency where you want to obtain the measurement. So I haven't tried it personally, but I thought it was a good idea.
That would be brilliant, because some of us talk about metronome in the adult world, frequency even. This would be the equivalent in the pediatric world.
Yeah. Good.
Yeah, you showed an example of an impedance spectrum that didn't make the cut. You threw it out because it didn't look right. And then it was that the reactant, low frequency, both real and imaginary parts were bending over, heading towards zero. And that's pathognomonic for a leak. So I wonder how often that might be, a leak around the mouth or through the nose. How often might that be fouling you up if that is in fact typical?
It's pretty typical. Like they have trouble making the mouth seal. Like the oval, there's only like one option for the mouthpiece. It's a little too big for some kids.
Okay. So that might be something to target. That might get you.
I do think, rapid breathing, not having a full mouth seal gives you those kind of erroneous results.
The other thing I want to ask, topic is, did you give albuterol bronchodilators to the normal kids? See what that did to the impedance?
So I don't have controls. I'm just basing on the published data.
Because when you said the wheezy kids were normalized, they were normalized to non-treated normal kids.
Yeah.
So, which is maps not an entirely fair comparison. Because one thing I noticed about your impedance spectrum, the real and imaginary parts, the fractional change from the wheezers to the normals at every frequency was pretty much the same. And it was the same in both resistance and elastance. So I'm asking myself, what could cause that? And one thing that could cause it potentially is a small lung. So I'm wondering if you have any sense of whether the lungs were smaller and something to do with it.
It could be.
Yeah, they could be. one, we have a gestational age cutoff, so they are, term children but that could also.
You have, birth weights, because they were small for dates. Probably the
Yeah,
small ones as
yeah, I
well.
am collecting all of that information.
Okay,
Yeah.
And then there's the ethnicity of
Yes,
these children.
yes.
Yeah.
Absolutely.
Fine.
Jeff, you had a question?
Oh, I was just gonna add, yeah, the fact that we found this inversion of the X and the R, the atypical pattern with the faster breathing does correspond with data that played around with at one point. Showing that, yeah, with the higher breathing rates, especially with breathing patterns that are more square wavy like, you tend to get harmonics right in the frequency range of oscillometry. And that can definitely perturb the lowest frequency measures in oscillation, 5 or the 7 hertz in this case.
So actually, I was surprised that it looked like, there was a segment that certainly seemed to improve with albuterol. And, very often with kids, you have those, the majority of those who are perfectly well and then episodic, usually viral induced, they'll have an exacerbation. And then there are kids who will have symptoms in between exacerbations. Besides your control question, your asthma control question, any feeling about, the pattern of exacerbation or wheezing episodes?
Yeah, so we are collecting all of that. Like we have surveys and then I do EMR chart reviews every time they show up to the ED. So I haven't looked at that specifically, but every wheezing episode we're capturing as during the study. And I will say that in our population, like when I've done some epic searches on visits, like of our 119 kids collectively, they've had like over 1,000 ED visits. So they're frequent flyers.
Frequent flyers, yes. Ron, anybody?
Je vais vous poser la question en français.
Oui.
Qu'en est-il de la grandeur? Parce que, tu sais, un enfant de 1 an n'a pas nécessairement 90 centimètres parce que ça prend les valeurs de référence. La grandeur des enfants, qu'est-ce que vous avez fait?
Oh, for children, especially younger ones who were, let's say, under 90 centimeters of height, which is sort of the cutoff for vaccines. So what did you do in terms of normal values for?
There's a small number, I think, that were under 90 centimeters, and I just used the same.
Right.
Step over the bus. There you go. Now you're in the shot.
Oh, okay, perfect. Okay. Is there any, I don't have a full view of the.
I think I saw Laura take over the screen.
I am here.
Oh,
Laura,
perfect.
welcome.
Thanks.
Well,
I'm going to start sharing.
yes, and actually,
Yeah.
yes, please do. And so let me introduce Lara Maria Galleda, please excuse me if I messed up your name, who's from University of Guatemala, who's going to report on a preschool cohort that she's been following in Guatemala. So take it away.
Thanks.
Oh, yeah, share screen.
She's
There.
Okay.
Okay, perfect.
Perfect. Are you seeing the presentation?
Yes.
Perfect. So, good morning to all. My name is Laura Grajeda. I am from the University of Georgia now, although I worked previously at Universidad del Valle de Guatemala. I want to start by saying thank you for having me here presenting our research with you. And I want to say that I'm very excited to all the learning that I'm having during this seminar. Today, I'm going to present the study reliability sub-study of pulmonary oscillometry of Guatemalan preschool children from the Household Air Pollution Intervention Network trial. Globally, around 2.4 billion people cook daily with biomass in open fires or inefficient stoves, resulting in high exposure to household air pollution. Exposure to household air pollution has been recognized as responsible for diseases like COPD. The theory of the early origins of disease proposes that diseases like COPD might start because of earlier harmful exposures earlier in life. Because of that, our group aimed to examine whether early exposure to household air pollution has an effect on a reduced lung function during childhood. The Household Air Pollution Intervention Network trial offers a setting to answer our question. In Guatemala, this trial enrolled 750 pregnant women who were cooking with biomass fuel and randomized them one-to-one to receive either a liquefied petroleum gas stove, free fuel, and behavior check messaging until their child aged 1 year of age, or to continue cooking with biomass fuel. To the right, you can see the effect of the intervention on the prenatal HAP exposure. The first two columns is baseline, and you see how the exposure is similar, but during pregnancy after the intervention, the exposure is reduced in the intervention group. The children has been followed since then, and in Guatemala, we plan to follow them until they are 7.5 years or more if we have the funding. During all this time, we have been collecting several measures of personal exposure to household air pollution. And since they were 3 years, we started collecting also respiratory oscillometry measures. Respiratory oscillometry is a lung function technique that is highly recommended for pediatric populations. However, there are some challenges, as our previous speaker told us, of conducting respiratory oscillometry in HAPIN. First, in our setting, measures are collected in the participants' homes of rural and impoverished settings in Guatemala, instead of doing in a clinic or a controlled setting. It requires young children to breathe quietly through a device, in our case, for many 20-second periods. Also, air leaks or obstructions of the flow result in measurement artifacts. The manual removal of the artifacts using commercial software is generally very time-consuming and requires expertise. Having random measurement error of the outcome can result in a loss of precision of our effect estimates. And finally, we are interested in capturing a typical pulmonary function rather than acute changes or a measure from that specific day. The reliability of this method has not been demonstrated in our setting. Because of this, we propose a reliability sub-study with the objective of assess the reliability of pulmonary function measurement in 3-year-old children using respiratory oscillometry in rural Guatemala. Specifically, we aim to estimate the intra-class correlation of tests conducted on the same day and consecutive days. Second, to assess if the intra-class correlation improves when applying different artifact removal approaches. Our design was a 4 repeated tests per child. We conducted this study from February to May 2022 as children were aged 3 years. So when the children aged 3 years, we visit them at their houses on 2 days. For each of the days, we conducted 2 tests. And for each of the tests, we conducted between 4 to 8 measures as were needed. To conduct these oscillometry measures, we use the Thorasys Tremoflow C100. We use a frequency range between 7 to 41 Hertz. Our measurements were 20 seconds in length. And we followed the recommendation standards by Kin about the child position. And for this presentation, our endpoints are R7 and X7. We thought to compare 3 different artifact filtering methods. We wanted to compare the Tremoflow method, the 3 standard deviation method, and an in-house developed method. As far as I understand, the Tremoflow identifies leaks using negative resistance values. It identifies obstructions using resistance or reactance outside 3 standard deviation from the mean. And when a leak or obstruction are identified, the exact point is removed from the time course data. The measures are considered valid when at least 70% of the points are valid. Then a measure is summarized using the mean. To calculate test, we selected the 4 valued measures which have the closest values for each OSM point or oscillometry point. This is not the standard approach, and I would like even another opportunity to talk more about this idea. For the 3 standard deviation methods, I have highlighted in blue what is different from the Tremor method. So for the identification of obstructions, we are using R7, X7, or C7 outside 3 standard deviation from the mean, and this is iterated 3 times. And for the exclusion, instead of excluding this exact point, we are excluding the whole breadth. And for validative measures, we are selecting those that have at least 4 valid breadths. And for our in-house filtering method, again, I'm highlighting what is different from the previous methods. For the leaks, we added that an R7 or X7 remains flat in at least 50% of the breadth. For the identification of obstructions, we use R7, X7, or C7, but now outside 1.5 interquartile ranges from the median. And instead of summarizing the measure using the mean, we will summarize the measure using the median. Regarding of analysis of reliability, we calculated the intraclass correlation coefficient of within-day child test and between-day child tests. The intraclass correlation measures how well children can be distinguished from each other despite measurements error. The higher the intraclass correlation, the more reliable the measure is. Here I present an example of the application of our in-house filter for the 3rd measurement of children 33001. On the left, we have the time course data. At the bottom, we have the volume and the flow, and at the top, the X7, R7, and C7. The vertical lines represent the different breadths. The color green represent breadth that, based on our in-house filter, they are going to stay, and in pink, those breadths that should be removed. We will start with trimming the ends because these are not whole breadths, so the ends are dropped from the measurement. And then we can also remove breadth number 3 and breadth number 6 because according to our in-house filter, they are obstructions. And lastly, we are going to drop breadth number 7 because it might be a leak. Okay, here this is the same measure, but now I'm presenting the distribution. At the top, we have for R7, and at the bottom, we have X7. To the left, we have before filtering, and to the right, after filtering. So if we focus our attention in here after filtering, you see that the leaks that were around value of 7 in R7, a value of 0 in R7 are removed because of the filtering. But these obstructions right here around the value of 20 still remain, a residual part still remains there. The green is the median and the blue is the mean. So you can see how the median maybe is a better summary statistic for this distribution, given that the median is less sensitive to the obstructions here or this tail of the distribution. For our results, this is the data. This table presents the data remaining after applying the different artifact filtering methods. For our 3 standard deviation method and our in-house algorithm, around 50% of the data is dropped. Only 50% more or less remain of the time result points and the breadths. However, if we go to the test and children level, we see that maybe just around 1 or 2% of the data is dropped. This other figure presents the reliability results. To the left, we have the R7, and to the right, the X7. To the top, the ICCs for within day, and in the bottom, ICCs between day. So when comparing the different measurement quality control methods, overall, the method that produces the higher reliability is the in-house method, here and here and here, and only for the R7, the tremor flow was the the one. Another thing interesting is that in the raw data, this ICC is very high, and this might be possible because the artifacts between the tests that are being compared are correlated. So for conclusions, we demonstrated high reliability of ozone pulmonary function tests within the same day and between subsequent days in 3-year-old children in rural Guatemala. These ICCs are similar to those reported by Robinson et al. In Australian children. Overall, the in-house filtering method resulted in higher ICCs than the other methods, probably because the median is less sensitive to residual artifacts than the mean. The high ICCs for tests on the same day when using the raw data may be due to a high correlation of the artifacts that occurs on the same day, or perhaps deposition or other things. Access to in-house artifact filter methods for us is an important opportunity to advance research on the validity of ozone. Our next steps are to conduct manual quality control of measurements by a pediatric pulmonary function expert, and we want to use these manually clean measures as our gold standard. And then to continue to explore other algorithms for artifact identification. For example, we have thought on calculating the standard deviation or the interquartile range at the child level instead of doing it per measurement. Or identified obstructions using resistance versus flow and reactance versus flow profiles, as other researchers have suggested. So I finished with the acknowledgements with the research team and with the funding that makes possible this research, and of course to the participants of the happiness studies. Thanks so much.
Well, thank you so much, Laura. Question in-house? When you look at the data as you cleaned it and you look at the values for the children, did the values change depending on which breaths you eliminated?
Actually, what it changed more is the standard deviation of the measures, and the mean most of the times is reduced because approaches 0. So it does reduce, but mostly standard deviation. What it does.
Yeah. Well, Larry, can I ask you to stop sharing your screen so that we can?
Yes. Stop share.
Yeah. All right.
Gallery was.
Where's gallery?
You had
You go back to where you were.
Oh, thank you. All right. Other questions? For the people who do a lot of QA, like Ron, would you like to comment?
I have a question.
Okay,
Sure.
where's that
So,
question?
can some of the variability in a measure be due to real biological variability? Like I have seen that sometimes I have seen in some research that kids with disease have higher reliability within this measure than kids without disease. So my question is, to what extent is it risky to remove real biological variability when I am trying to filter in for artifacts?
Any comments? Charlie?
Yeah, that's a really, really good question. When they're dealing with asthma, where it's coming and going, there's some old studies that I always quote when I'm writing about this for spirometry that shows that variation in spirometry within a session and failure to be able to do spirometry is correlated to disease. So I totally agree with that. Getting rid of artifacts that are technical in nature, fine. But getting rid of artifacts that are biology, maybe not so much, depending on the setting.
Right.
Well, perhaps you can think about what the variable factors might be. I mean, a couple that come to mind are changes in mean lung volume and changes in what the glottis is doing. maybe they are swinging around, varying of the measurement cycle.
Well, the other one I think about, Jason, in particularly the example that was given are vocal cords.
Yeah.
So
A lot
vocal,
of code, there's a lot of code, yeah.
yeah, the vocal cord dysfunction is much more common than you would think. I always thought it was an artifact of national Jewish patients, but it isn't. We see plenty of it. So, you know, to the extent that they're doing that or glottal. types of
Yeah.
movement.
Yeah.
Great.
Yeah, it's a pretty deep question. If your objective is to find what is happening in the lung, then vocal dysfunction is actually an artifact, right? But of course, you don't want to throw that out because you misdiagnose the patient, right? But a leak, technical artifacts, as Charlie said, you've got to get rid of. But it is challenging sometimes if once we break the measurements into saying this is small airway resistance and this is large airway, it's actually just respiratory mechanics that you're measuring, and you're capturing respiratory mechanics, including technical artifacts. But now when we subdivide our measurement into different things, you can no longer be sure of those things with artifactual things. And so your variation R5 minus 19, or your variation X5 AX, and so on. You want the standard deviation. Our technical standard is recommending that your coefficient of variation of R5 would be less than 10% for adults, 15% for children. And it actually goes on to say, or in challenging, I forget exactly the wording, but it does open the door if you have difficult patients, or it's not meant to be difficult. It's just, it opens the door that if you have disease, maybe you want to open up that number from 10% to something larger. And it's a recommendation. So I think that's the current state of affairs, is that we should recognize that variability is associated with disease, and we don't have to throw out things that are less than 10% when we have this situation. Larger than.
Yep.
Last So Laura, you're to be congratulated because that's it's a big source of consternation for us who are clinicians. I think there's no substitute for having the technicians acquiring the data look live at the facings as they're gathering them, and that will actually get you through with better quality studies with rejecting less. So I think well-trained technicians is part of it. The other thing is that, as you're pointing out, the manufacturers have different algorithms for assessing quality control, and that may explain some of the differences we see between devices that we're trying to harmonize. And then my last point would be that going forward, we're even wondering whether manufacturers should be having an option where their device will be only pressure flow transducers, allow us to gather the raw data and access it on softwares other than their own software for doing the processing, not only the modeling, but also the quality control. And that's a question that will be answered over some beers with the manufacturers this evening. I don't expect anybody to weigh in on that right now.
Okay, great. Well, thank you again, Lyra.
Thanks for your comments.
Okay, so our next speaker is Misha Fotavati, who's a medical student at McGill, who's been working with Ron for the last couple of years and was kind enough to give an assist to a project we were doing in adolescents living with obesity. Yeah, is that? Cool.
Thank you, Dr. Lance, for the introduction. So hello, everyone. My name is Misha, and I'm an incoming third-year medical student at McGill University. And I'm really excited to be presenting this project, looking at lung mechanics in adolescents living with obesity, and share some insights we gathered from both spectral and intrabreath oscillometry. So when I first started this project, I wanted to understand why a project like this would be clinically relevant. And we know that 17% of adolescents are obese, according to the Public Health Agency of Canada. And so this makes it a critical public health issue. In particular, when we have a cohort of people who are between the ages of 12 to 18 or 12 to 19, this is a critical time where we can intervene. We could start exercise programs, dietary intervention. We can even propose bariatric surgery, specifically if we understand that there's alterations in their lung mechanics. And so we're going to talk a little bit about what we see in when it comes to obesity in lung mechanics. And so what do we understand already? Well, there's a lot of literature that suggests that obesity modifies lung mechanics, particularly in the small airways. And mechanisms include increased chest wall mass, systemic inflammation, and metabolic dysregulation. And in adults, obesity is associated with a restrictive lung pattern due to just the sheer mass on the chest wall. And so we often see a decreased total lung capacity, FEV1, FVC. But in children, what's interesting is that obesity often shows an obstructive pattern. So often a decreased FEV1 to FVC ratio. And this is often attributed to the phenomenon of airway dysynapsis, where the lung parenchyma grows at an accelerated pace, disproportionately compared to the bronchial tree. And so what do we understand about how childhood obesity in those who are non-asthmatic, how does that interact with lung mechanics? Well, the Wilhite paper published in 2022 showed that that obesity does have an impact on lung mechanics, specifically when we look at resistance. And we toyed around with this concept about R5 minus R20. Does it really represent small airways? But if we look at it like that, we see that there is a correlation between resistance and percent body fat in children who are obese. But we wanted to understand more about how this influences adolescents. Like I said, because there's emerging data that perhaps later on this can predispose them to adult onset asthma and even COPD, which comes with significant morbidity. And so our objective was to quantify and characterize alterations in lung mechanics due to obesity in adolescents. And we wanted to examine correlations between lung mechanics and anthropometric measurements, so body mass fat distribution. We wanted to compare the sensitivity of spirometry, spectral oscillometry, and intra-breath oscillometry in detecting obesity-related lung function changes. And so this study included 38 participants, 18 non-obese adolescents and 20 adolescents living with obesity. We defined it as a BMI over the 95th percentile, and we excluded those with asthma history. And all participants underwent anthropometry and body composition analysis via DEXA. And so we also conducted, obviously, spirometry and both spectral and intra-breath oscillometry, which is a novel and emerging technique. So just looking at the demographic data, you see that the weight, the BMI, and waist-to-hip ratio are evidently different between the two populations as they're adolescents living with obesity. However, their age, their height, and their sexual maturation ratings were not significantly different. And the mean median age was about 16 in both the controls and the adolescents living with obesity. And so to begin with the results, as we noted in the Wilhite paper, we had a similar tendency here. Spirometry didn't really pick up a difference amongst all the parameters between adolescents living with obesity and controls. However, there are some interesting things you can pick up. For example, the FVC and FEV1 were both greater in this population, as well as the FEV1 to FVC ratio. And so we're going to prompt the audience maybe later on as to why this might be, but there were no significant differences in the two populations. And then what everyone here is interested in when it comes to spectral oscillometry, we found that there were significant differences. And once again, it's in this R5 minus R20, the frequency dependence of resistance, as well as the R5% predicted. And so we could perhaps extrapolate that there is some resistance in adolescents living with obesity, perhaps in the peripheral airways, that is manifesting in relationship to their obesity. But what's particularly something that I was very curious about was when I saw the area under the reactance curve and the FRES, was that those were also significantly different, and whereas their X5 was not. And one hypothesis that the Wilhite paper had proposed, because they had found something similar, was that perhaps the lung parenchyma and the chest wall is not particularly altered in children living with obesity, but their total lung reactance or total lung stiffness or related to peripheral airways had an influence. And that's why we had a difference in FRES and AX% predicted. But we wanted to prompt once again the audience as to why perhaps this might be the case, especially looking at the reactance at 5 Hertz, seeing that we don't really have a significant difference. And so we just wanted to present that R5 and FEV1, so spirometry and oscillometry parameters, they do correlate well with one another. However, even though they have a relationship, it seems that perhaps spectral oscillometry, and this is not anything new to anybody, happens to be more sensitive perhaps at detecting these beginning changes to the peripheral airways. And then we looked at intra-breath oscillometry. And like I said, this is a novel technique looking at oscillation mechanics at 1 frequency at 10 Hertz. And what we found that there was a significant difference in the end inspiratory resistance. And this was something that was also curious because often we find that if it's a characteristic of the airways, it would perhaps be more manifested in the end expiratory resistance. However, we did note that both the expiratory resistance and inspiratory resistance correlated quite strongly with body fat percentage. And you could see that in the adolescents living with obesity group, those are marked in red, that they all obviously tend towards higher body fat percentage, but also higher resistance at both end expiration and end inspiration. And this is specific to intra-breath parameters. And so in conclusion, we seem to find that adolescent obesity correlates with higher airway resistance, R5 and R5 minus R20, and it suggests that there's perhaps an impaired airway function. But we also see that it increases resistance in end expiration and end inspiration, and perhaps there's some airway restriction. And so although spirometry correlates with oscillometry parameters, it may not fully capture the subtle changes in lung mechanics. And perhaps in the clinical setting, if we do capture these beginning changes, we can intervene earlier and perhaps implement those exercise programs or propose bariatric surgery if there's already an implication in terms of their lung mechanics, even though they don't have disease. And so with that, I thank you all, and I open the floor to any questions you might have.
Larry? Very interesting. I haven't studied obese as adolescents, but I had a good look at obese adults. So I might offer a perspective, might be wrong. Major signal in obese adults is actually an AX for the reactive part. And I'm pretty sure it's not airway narrowing, it's collapse of the lung periphery. So it's de-recruitment, which makes the lung look stiffer. I'm actually surprised you got such a big signal in airway resistance. You do see a little bit of this in adults, but so anyway, it could be that it's a younger lung, who knows? But my guess is that when you're breathing chronically at a low lung volume, you're getting de-recruitment of some peripheral units, and that's what's causing that. And as regards, a different effect in spirometry, when you take a deep breath for spirometry, you probably open everything up. And my understanding of it is that severely obese folks, generally speaking, unless they're asthmatic, can actually perform fairly normal spirometry. You can take a deep breath. They can open things up. And the de-recruitment that happens when you come down will eventually, it might limit FVC. But de-recruitment takes a little bit of a time to manifest. It's not just a function of pressure. Things don't collapse down just because you go to a low lung volume. So if you're breathing chronically at a low lung volume, things are going to de-recruit and achieve some kind of steady state. And that, I think, is what you're picking up with oscillometry, which makes it a very different kind of way of probing the lung.
Very interesting. Thank you.
So one thing to follow on in that is one of the difference between children and adults is that the children have much more flexible shuttles. So that may be playing a role here, but I was intrigued by your AX data without much change in your reactance at 5 Hertz. And the only way you're going to get that is by a change in resonance frequency. So, because how else are you going to get a triangle to get to that? And so what would be causing that? And again, it could be the obesity, the chest walls changed.
Well, usually by adolescence, your chest walls a lot closer to adults.
Much closer. And then again, as we get older,
That's all.
that's a different.
Goes up
issue.
yet. Plateau. Or now you want to look at it.
Stiffens again.
Very good point, Charlie. Another mechanism And it was part of the reason why AX is sometimes argued to be a useful measure, is because it's multi-frequency. X5 or this is X7, I guess, can be affected more by noise. So here you're doing statistical measures between the obese and non-obese, and you might have just more variability in X5 because of noise, but not in AX, because you're actually benefiting from the other measurements at other frequencies until you get to resonant frequency to actually take care of that effect somewhat. So you might have better statistics with AX than you do with X5. So you get significance then.
Right, but perhaps Charlie's, I mean, that's absolutely right. But AX doesn't just involve stiffness, it involves the inertance of the respiratory system as well. So if you did have some effect on some massive structure, I haven't thought this through very carefully, but somebody.
We tried to look for correlate because we actually took our DEXA scan, and sort of, which is chest wall mass versus abdominal mass, and when we looked for correlation, it was actually 12% body fat. I was a little discouraged because I really thought I was just slicing up and say, okay, it's all in your belly pushing out or on your chest pushing out, but we didn't see it. And it could be some of these people did not seem obviously obese. Children with obesity, they grow. So some of them were like really tall, like you're 15, like they're quite large. So they do hit the 95th percentile, but their habitus didn't fit with what you think about.
So this is the objection to BMI. In a growing kid.
Yeah. Well, that's why we use percentile. And when
Do you have the intrographic loops and the KRD and AXP data?
So I know one of my collaborators, they just sent me all of the tremor flow data. So I think we do have it. We have the graphic representations of the spectral, and I would be surprised. Actually, no, we do have it. I actually did it. Yes. Dr. Dandron is looking, he's like, yes, we do have it.
I think
Yeah.
the question of whether or not this is primary for limitation, the loops will be very helpful in
Okay.
terms of
Okay.
looking at the.
And a small enough cohort, you can put them all on a panel and do my favorite thing is actually looking at the raw data for the stats.
yes. Great.
Yeah, I was just curious, Rachel Eddy spoke earlier today. I know that she has a study that she had published earlier that, did some lung imaging as well. I'm just wondering with obesity, has there been any imaging done, MRI or anything like that to correlate with lung function?
There's probably been some CT, I don't know what MR is.
Yeah.
I see Rachel online, maybe she could actually, Rachel, you want to chime in?
Oh, she's
educate us?
Yeah, I can actually speak to a little bit. Perhaps less so in adolescence. We're quite limited by, at least for xenon MRI, and for the size of patient that we can image. When they get too obese, they don't fit in our radio frequency chest coil. It's a flexible vest, at least the ones that most of us use, so it allows us to accommodate a little bit more. But the greater you push that coil, the worse image quality you get. And so in Vancouver, at least, we've pushed like 120 kilos, and it's tough. There was an abstract at ATS this year that showed increased so the last slide that I showed, without getting into too nitty-gritty details of xenon, increased membrane and increased red blood cell signal in people with larger BMIs. That was a US study, so unfortunately their participants tend to all of the cohorts I've seen, they tend to have higher BMIs than any of the cohorts that I've had in Canada. So we haven't quite uncovered that physiologic effect, and it's been kind of bugging me for a few months. Sorry to make that comment. I see a lot of people laughing, but it's just the state of what it is. Anyway, so it's hard to uncover, it's been bugging me. Is it physiologic? Is it an imaging artifact? Is it just the weight of the chest that's sort of compressing the lung? The lungs are stiffer. That's what we're hearing a lot, I think, with this presentation. With CT2, some of the analysis that I've done, I have had to correct for BMI because inevitably you have greater image noise with larger bodies because they attenuate the x-rays more. So you either have to increase the radiation dose or you get a lot of image noise, which inflates your emphysema metrics, for example. You can't resolve as many airways. So a lot of it is more technical when it comes to obesity. I guess that's the best summary that I can give you.
Do you have a question for that?
No, I was trying to answer the question for adolescents. So we use it regular CT chest and skeletal muscle fat composition, looking mostly at the pectoralis muscle, but I have no idea about the adolescent patient population. But for adults, for large population studies, we do fat composition of the skeletal muscles.
Oh, that brings to another point. There's a new software that Luis, I don't know if he's here or not, is playing with called Total Segmentator.
Little segmentator, yeah.
Yeah, and
It's fantastic.
so while you have hands-on experience, so why don't you just tell us a little bit about that if you've made it?
I haven't used Total Segmentator myself, but I've seen the results and it's pretty remarkable. Open source, free tools for anyone. You can give it almost any CT image and it'll segment your structures. It's free, it's open source. I believe it's built in 3D Slicer. So 3D Slicer is a relatively intuitive tool as well. So it's pretty impressive it can segment the lung. I mean, the lungs is a relatively straightforward, but it can segment lungs, airways, lung lobes. I think you can do the pectoralis muscle. You can do I've also seen the spinal muscles reported. And I think they're segmented. You can actually look at the vertebrae, all of the above anyways, in the space of the chest, but.
Yeah, we've operationalized that in my lab and we're looking at it as we speak, and we may actually have some stuff to present at ATS. Okay, stay tuned.
Awesome. That's great.
Great,
Thank you so much.
thank you.
Good job.
So our last speaker in this segment is Danny Millay, also from McGill and another medical student in Ron's posse.
Brian Ross. Brian is good.
Sorry.
I'm not coaching Brian. You're here. I won't steal your.
Oh, okay. Well, the mechanical engineering. Thank God, somebody knows what we're talking about. Okay, and he's going to talk to us about mechanics in COPD using a device that I believe Ron you developed, right?
Oleg, who's in the audience, and myself, yeah, we hold the patent on this device, so everybody has full disclosure. So we will await your comments again.
Just making sure it's the right version.
Yeah, but it is or not.
Let's do that. We no longer have.
All right. So hello, everyone. My name is Danny. I'm a mechanical engineering candidate at McGill. I also have a bit of background in biology and computer science. And today I'll be presenting the study entitled Measuring Lung Mechanics in Patients with COPD using the handheld portable expiratory occlusion monitor, also known as the REOM. So I've been working on this project under the supervision of Dr. Ross for the past year. So I'm eager to present what we have so far. So a bit of background about COPD. As you may already know, it's a third leading cause of mortality worldwide, usually caused by inhalation of noxious gases. And it results in a fixed airflow obstruction, as well as intolerance to exercise, chronic cough, and shortness of breath. And the gold standard for diagnosis of COPD for many decades has been a spirometry, and more specifically, a post-bronchodilator FEV1 over FVC of less than 0.7, as well as categorizing the severity of the disease through the percentage of prediction of the FEV1 value. And spirometry has many limitations, such as the fact that it can be very hard for patients with advanced disease to come in for spirometry and perform forced respiratory maneuvers, as well as the need for multiple reproducible tests, which cannot always be reached, and as well as trained personnel to operate the equipment, which itself can be very costly. And finally, there's also the concern of disease transmission and infection control regulation. So oscillometry does have many advantages over spirometry, since it's through tidal breathing. It's non-invasive and effort independent. And it also bypasses many of the infection control concerns. And it's even recommended by the American Thoracic Society and European Respiratory Society guidelines for patients with very advanced disease, very advanced COPD. And the two oscillometry metrics that we're interested in looking at in this study are the resistance at 20 Hertz and 5 Hertz, which for which evidence shows that there is some specificity in characterizing resistance across the tracheobronchial tree, and which have been shown to be able to discern resistance patterns in COPD versus healthy individuals, and that can be even more sensitive to aeropathology than spirometry. And despite the many advantages oscillometry has over spirometry, there are still a few small challenges with oscillometry, such as the lack of potential for remote patient monitoring, as well as a perceived mathematical complexity of oscillometry, which leads to limited adoption of oscillometry within respiratory clinics. So we looked into another device called the Rapid Expiratory Occlusion Monitor, or the REOM, which also allows to characterize lung mechanics during quiet tidal breathing. It's very light and portable. It's like this big, and it's relatively inexpensive and can be linked via Bluetooth to a tablet, onto which data is uploaded in real time. And so the working principle of the REOM is the flow interrupter technique. So it's there's a shutter valve which is magnetically closed at the beginning of respiration, and as the participant exhales, the initial slight buildup of pressure opens the shutter valve as the patient breathes out, which allows the device to measure the initial pressure as well as the flow during the time of expiration. So the device outputs two resistance values referred to as the slow REO-S, the slow resistance, and REO-F, the fast resistance value. The fast resistance value is calculated using the peak pressure right before the shutter valve opens, as well as the peak flow within 50 milliseconds after the opening of the shutter valve. And the slow measurement of resistance that is calculated by this device is also uses the peak pressure right before the opening of the shutter valve. But in this case, the flow is extrapolated using the natural logarithm of flow versus time graph. It's basically the y-intercept of this graph that is used to calculate the slow measurement of resistance. And what's interesting about the REOM is that it's been investigated by a study in 2021 by Lundblad et al. In the pediatric asthma population. And what they found is that fast resistance value strongly correlated with R20 that is measured using the TremorFlow, and the slow resistance value computed by the REOM correlated with R5 using the TremorFlow. And they also found that the slow resistance value, so REO-S, was able to discern between asthmatics and non-asthmatic patients. However, given the important pathophysiological differences between asthma and COPD, these results could not simply be extrapolated onto the adult COPD population, hence the relevance of this current study. So the REOM could be very interesting for those unable to undergo a pulmonary function test, And it can provide data in very short time frame. The test is very quick. And it does not require as much technical expertise or skilled personnel as would a spirometry or an oscillometry test. And it has a potential for remote patient monitoring, since it can be taken home by the patients eventually, hopefully, and where they can measure the resistance values at home. So the objective of this study was to measure the concordance or agreement between the REOM metrics, so REOF and REOS, and R20 and R5. So more specifically how REOF correlated with R20 and REOS correlated with R5, similarly to that Lundblad et al. 2021 study. And we wanted to investigate if the REOM was able to distinguish between Gold 1 and Gold 4 COPD, so mild versus very severe COPD. And finally, we aim to collect some participant user experience using questionnaires to see how they enjoy using the device. So what we did is that we recruited adult COPD patients from the Montreal Chest Institute, so both male and female, and Gold 1 and Gold 4 COPD. And we scheduled them for a single 2-hour visit at the Center of Innovative Medicine to undergo these three tests in this order. So we started off with a tremoflow test using the standard 5 to 37 waveform oscillometry test, which was immediately followed by a REOM test. Here we've used a coefficient of variance of less than 15% for both of these tests as acceptable, at least three measurements for each. And finally, we concluded the session with a full pulmonary function test. And at the end, we asked the participant to rate their experience with the REOM through a system utility scale, the validated SUS scale. And we included males and females of at least 40 years or older with COPD and at least 10 pack years of smoking history, which have been diagnosed with either Gold 1 or Gold 4 COPD. And we decided to exclude any patient who had a history of comorbid asthma, or were on current use of home oxygen, or had any chronic respiratory infection, or an exacerbation of COPD within the last 4 weeks of the study visit, or simply any contraindication to respiratory testing. So this is basic demographic and lung function information that we obtained from the participant. So as you can see here, we have a slightly older Gold 1 and Gold 4 population, but they do, as expected, have a slightly lower smoking history. And as you can see, we have an equal distribution of male and female participants. Now, for the lung function measurements, we have, as expected, the Gold 1 population has a mean of 87% predicted FEV1, whilst the Gold 4 has a mean of 23% predicted FEV1. And finally, here, the DLCO, we have a higher value for Gold 1 participants than Gold 4 participants as expected. And now these are results that were collected from both the tremoflow and the REOM. So here, also as expected, we had resistance at measured at 5 Hertz for the Gold 1 population, being lower than that for the Gold 4 populations, and similarly for the resistance at 20 Hertz. And here, if we look at the REOM values, we also see that difference with 0.246, a value of 0.246 for the resistance of the REOS resistance versus 0.625 for the Gold 4 populations, and similar values for the REOF measurement. And finally, as you can see, the system utility scale score was 98% for the Gold 1 population and 94% for the Gold 4 subgroup, which shows a good positive participant experience using the REOM. And now, these are a bit of the results we have so far for the study. So as you can see, we tried to see if there was a correlation between Rio S and R5, and we found a significant correlation with a coefficient of correlation of 0.9. And the blend-Altman test did not reveal any sign of proportional bias. So there was good agreement between the Rio S and R5 measurement. And similarly here, using the Rio F and R20, we were able to find a significant correlation and a strong correlation with a correlation coefficient of 0.9. And again, there was no sign of proportional bias, and hence good agreement between the two methods. And then we also developed a machine learning based algorithm, a gold classifier, may I say, to see if R5 and R20 were able to discern between these gold 4 and gold 1 groups. And we got 100% accuracy in this classification. So the algorithm was able to discern gold 1 from gold 4 COPD patients. And similarly here, when using the Rio F and the Rio S, so the fast and small and slow resistance measurements from the RIOM, we also were able to successfully discern gold 4 from gold 1 population using this machine learning algorithm. So in summary, we found that Rio F correlated with R20 and Rio S correlated with R5. And for both of these, we did not find any evidence of systematic or proportional bias between the two methods. And the RIOM metrics together were able to differentiate mild from severe COPD, so the gold 1 from the gold 4 group. And the participants generally reported a good user experience with the RIOM. And we hope that in the future, we may be able to provide these RIOMs to participants or to patients to use at home to measure their lung resistances at a distance and have the data transmitted in real time to their respiratory clinician. Thank you so much, everyone.
Very nice. Thank you.
Stop sharing your screen while you're up there.
Yeah,
Sure.
Bring everything.
perfect. So, yes.
Yeah, very nice. I didn't follow the details about how you calculate those two Rio parameters,
Right.
but I mean, theoretically, an interrupter does essentially a forced oscillation because it's not an oscillation, it applies a broadband signal to the respiratory system. It's close to a step response, from which, if you do the division of the calculated transfer function and the frequency domain, you can convert into an impedance very straightforwardly.
Right.
But so I wonder, I mean, you're an engineer, looked into that, to the relationship between the two and how that algorithm they use
I have not.
relates to that?
I'm actually starting in mechanical engineering this fall. Yeah. But I'll definitely look into it. Thank you.
Actually, I would urge you to ask the question to the gentleman sitting beside you.
This guy.
Other side. Oleg.
You're sitting over.
Oh, it? Oh, okay. Oh, okay, right, yeah.
Yep, so Oleg, want to weigh in on that?
I'm not sure I can give a very short answer in this. Yes, for this analysis, we used a two-compartment model. And if we talk about this effect in terms of RLC, resistance, capacity, inductance, post-occlusion waveform, it looks like discharge of two capacitance. One small capacitor, which represents upper airways, and bigger capacitor through bigger resistor, which corresponds to lower airways. And we have two slopes. To evaluate resistance of upper airways, we use peak flow, and calculation is maximum flow or threshold pressure before shutter opening divided by peak flow. For resistance, which corresponds to total resistance of airways, we calculate this flow by we built tangent line to the fragment of flow waveform in about 50 to 100 milliseconds after shutter opening. Find intersection with vertical axis.
Okay, I get the idea.
Yes.
I won't torture you anymore. But,
Yes.
but let me ask you then, since we're in the technical side of things, how long does it take for the valve to open? From the beginning when it starts to open to when it
Yes.
does open?
So basically, as the patient starts to breathe out, a slight buildup of pressure allows the valve to open right away.
Right, but it's not right away. It takes a while to
takes,
go from closed to fully open. How long is it?
I can give you answer very quickly. From maximum point of peak, before shutter opening till 0, it's about 8 milliseconds.
Okay, but that doesn't necessarily mean that's what the valve is doing. That's what your signal is doing. The reason I ask is many years ago, when I was a fellow at the Meakins, we did a lot of work on the interrupter. I went through all these questions about valve opening. I'm kind of interested in it. I mean, do you, for example, when the valve opens, do you see any ringing, high frequency ringing?
No.
Okay, because that suggests possibly the valve isn't opening as fast as you think. Because if it opens instantaneously, you would see ringing due to the oscillations of the gas in the central airways.
It happened when you use butterfly type valve.
Yeah.
When you use butterfly valve opening, yes, you can see this overshooting and these oscillations.
Yeah.
In our case, during occlusion stage, the shutter is attached by the magnet, and when pressure reaches threshold value, magnet is part of, and shutter is opened by the flow stream.
Okay.
So it's naturally opened with flow, which pushes it.
Yeah.
So it opens to about this angle.
Yeah.
And before it returns back, it takes like 150 milliseconds. So we collect data in first 100 milliseconds when shutter is open. So in this flow diagram, time interval between maximum pressure to 0 pressure, 8 milliseconds, and from 0 pressure to peak flow, another 15 milliseconds.
Okay. Yeah, look, I mean, it makes perfect sense that it's going to correlate.
So actually, it's surprisingly very fast.
Now, I'm just trying to understand the details, but this has nothing to do with it being, I'm not trying to suggest it's not a useful technique. It really is.
I noticed in one of your plots that one of the measurements of resistance gave you this one.
Yeah.
And this is the fast EO.
Yeah, exactly. Yeah.
Maybe some spurious results from the others. And one particularly high, so they're getting sort of higher pressures, correct? So how is the pressure measured instantaneously at some time point before the shutter opens? Or is it more of a continuous measurement, averaged, in other words?
I think it's the peak pressure within a certain time frame before the shutter valve opening.
So then I think the comments of Jason are right. I mean, if you get any kind of oscillations in those signals, or they're really sharp, then where you measure that pressure is going to give you that sort of thing. So if you were to average it over a few milliseconds, maybe.
Okay.
It's just a thought.
Right.
And this is more of a practical.
Yeah.
We have evaluated some very early versions of the Reno, and that opening that shutter is not that easy. And so I wondered, and I would love it, like if you have one that you bring in for us tomorrow to see it, I would love to see it. Because I wonder sort of in the patients with severe lung disease, whether or not you are getting the same measurements as someone using, because with someone with normal lung capacity, I found it really difficult to actually get the shutter to open.
Right. And it did require sometimes for some patients a bit of effort to get that shutter valve to open. But I think we discussed like having the pressure for opening changed, right, earlier.
Typical diagram is following. At the beginning of exhalation, the shutter is closed and kept by the magnet. And then we continuously measure pressure, which takes about 200 milliseconds to reach maximum threshold pressure. And after that, shutter is turned off, magnet is turned off. And in 8 milliseconds, pressure drops down to about 700 pascals to zero in 8 milliseconds. And next 15 millisecond flow reaches its maximum in about 15 milliseconds, peak flow. And after that, in this flow waveform, we see this decay, which you presented in your diagrams. So
Right.
this is typical timing. And frankly, for me as an engineer, it's really a little bit surprising because what I read before in articles of Janet Stokes, when people use a butterfly type shutter, they said it's extremely difficult engineering task to build very fast shutter. And when it opens very fast, you see these huge spikes. And when we build this type of opening, when shutter is opened not by mechanical force, but smoothly with airflow, flow reaches its maximum without overshooting it, without oscillations.
Yeah, but that must be because you're damping out those oscillations. Because the oscillations are actually due to the quarter wave resonance, acoustic resonance of the airways.
Exactly.
Bouncing like.
We see these oscillations later. I would like to talk.
Yeah.
After flow reaches its maximum, then it drops down.
It sounds like time for coffee.
Down to the bottom.
Coffee conversation.
Okay. Yeah, we'll talk later.
Okay, well, thank you all for this.
Thank you.
Very nice.
Problematic.
To everybody, in addition to coffee on the 6th floor, you'll find leftover soft drinks, nice tea from lunch. So if you don't want to caffeinate yourself too much, you do have an alternative.
When do we start again?
In 20 minutes.
What's that timeline?
Des lunchs aussi. Ouais. Mon timeline, ben, je veux dire, j'ai la timeline que j'ai fait pour tout. Genre, j'ai écrit mes respondés.
Yeah. Yes, I decided.
Ouais, ça, ben, c'était le gars qui présentait juste la technique.
I don't have that. That's why I was afraid.
Étais-tu au... Ok. Ah!
Oh, okay.
T'as pas qu'on a le droit de faire ça. Ah! Là,
Oh, yeah, yeah, the total
And it wasn't super. Okay, then.
It's gonna be,
The other thing is, we have. Oh, there we go.
Crazy.
Oh, thank you.
Yeah, they. But for the purpose of.
Yeah.
As long as it is. When she started in there.
But yeah.
Otherwise, they'll have better access.
Are you next?
Yes, but
Oh, I see. That's what.
Yeah.
And then the woman, and I had huge fibers, maybe 20 times higher than virus. Yes, and he said, I never seen this.
I know.
Right down.
Oh, no, that's right.
Scientist, you love
I'm like, could have brought it into the.
I was.
Yeah, just. It's like it was.
Yeah.
You know, when I was.
Kind of happened, and then summers.
I had to be.
I was like, kind of.
That is a site.
I told her.
Right, yeah.
It's like reading it.
All the rest.
That's so.
No, we take.
Yeah.
Like, but. Yeah, you have to.
Like that's all. I did the same.
Oh, God, it was like, we have to totally finish that.
That and the one about
I know.
I don't. Maybe. No, what's
Oh, no, it was after. That's right. Oh, you know, in fact, with the water pack, we brought it back.
I guess.
And then.
No.
Now they're going down like.
Maybe. It's one of my colleagues.
And it was.
What it is. But I'll definitely. I think it.
But also, it also took a long time. I had it.
It's strong.
Oh, there's always anything.
Further than other people.
Yeah, but wait.
It's open. But it was closed.
From the.
No, I would love to see it, like, if you think back to the.
Yeah, that's what I did it on purpose.
This wasn't when that was
Fine.
Just
Now you're from the device.
One of our students, Justin, actually.
Oh,
That's it. Well, I managed, but I did like that little thing. It's like a comfort thing. Like last time I went to Toronto and I was there with I mean, it's fine. I've done it. I wanna look up the- Oh, yeah, it was pretty high. Like, I thought it was functional, that's why you. And also to like arrive in the yeah, find like a big bus, but like, still like the ones we got. Oh, okay. So literally,
Multiple
our play was
correlation.
right.
That value.
And then it's like there. Okay. A lot of like in here, so you can do like hours. But at least it's yeah. Okay, that's not too bad. So in next, like, well, you can get it out. But when they're slightly really. I heard about that. Yeah, so that was. I know the airport was far. Did they talk about anyone?
Yes, why actually another.
Yeah, so sorry, I was asking like kind of investigate, but I really followed this, so I kind of came in. Leonard promised. Yeah. Having it. Then I'm like, how communicate? Then I'm like, okay, all right, we're gonna get our remember this, that's like, I'm brave that you
We need to keep one about.
yeah, I like made a bunch of R&D there. I just came on this last one. I heard. Oh yeah, you know. I was just like. My project happened was like I was on an impression. Right. That was like 2 months ago. Yeah. That's why we're like. I don't. Oh, it's. Oh, it's not them about this. And I'm like, oh, I didn't even know that they had, you know, kind of stuff where I was found. Anyway, hopefully.
Due to a central airway.
But yeah.
Right.
Yeah, because
If you do that
other model. What timeline? Well, I had an impression that it was ready in May. Yeah, me too. I was like, I can bring it to May. That means it's ready, right? And Aaron said it's ready on like your day.
I know.
I don't know. Yeah, anyway, so I don't know. But anyway, we thought we could try the best. We usually get residents. We don't have. Right out. Good timeline now. But Jonathan called me. Asked if I was yes, that's what we talked about. And you're
Day-to-day.
Oh, yeah.
I'm not really 100% sure.
It turned out that. Measure.
I can ask. I feel like I'm not really sure, so I think the answer was not okay. Yes, I was like, okay. Then after I'm like, you know what? I'll probably wait at this point after talking. I'm gonna.
We're not.
Yeah, well, actually, yeah. Something
happens. Headache correlated.
I just stopped offering. Back on. I'll yeah, I guess you're back, but I'll see you later. Are you eating dinner, right? Okay, yeah.
Actually, I have. The size of the bottle. On across the. That's also water that. Oh my.
The longer drive. It wasn't our first time, you know. The long man. I'm glad our flight actually made it and Anyways, so how do we? Danny's.
Spent like 5 hours.
We never got to that.
Anything else? Yeah.
Oh, you better
For the other
So for adults.
the way they're fine.
I didn't really watch that cross.
Oh, I saw this. Right? And just going to. Yeah.
Oh, okay. See that.
Very but it's yeah, formalism, oh yeah.
I want to come in.
It's fun.
I'm in Colorado. Yeah, I covered this water.
So I mean, but again.
The guy did for competitive.
Let's go for it.
Okay, everybody shut up and sit down. Ron tells me that we gotta get going again. think we ought to just go and get drinks instead. So I'm,
Yeah, she didn't know what.
ladies, gentlemen, the engineers are having a clam bake over here. My name's Charlie Irvin from the University of Vermont. In our last session of the day, we're going to be talking about ILD, which is an old favorite of mine, and then COPD again. So our first contestant this afternoon, you're Deborah.
That's right.
Excellent. Deborah's from McGill, and she's going to be talking about oscillometry, longitudinal change in lung functions in patients with ILD.
Okay, let's open this up.
Help you to touch.
They don't have what, sorry?
He says he hopes you know how to use it because he's not.
Well,
I'm a Mac.
all right.
Excellent.
I have to share screen, right?
Yeah, and presentation, yeah.
All right, here we go. All right, so thank you so much.
Oh, you can get rid of Rachel up there. Rachel, no offense, but we'll say goodbye. There you go.
All right, is that better?
Yeah, there you go.
Okay, so thank you for this invitation to speak again. Last year, I spoke about change in oscillometry and ILD in a cross-sectional study, and this is kind of the second part of the work that we're doing, where we're looking at change longitudinally in our same patients who we've already tested. So I do have some disclosures. Specifically, I want to highlight that the work that I'm presenting was from a research support by Bornher Ingelheim. So what's the rationale for this study that we're doing is, as you may know, interstitial lung diseases are a group of disorders of the lung parenchyma itself. And they're typically characterized by inflammation and a combination of lung fibrosis or lung scarring. And they tend to be progressive. And some types of ILD are reversible, but the majority of them are irreversible and lead to fairly rapid progression of scarring of the lung and fibrosis with restrictive impairment that we typically measure using forced vital capacity and spirometry. And in ILD, FVC has been a very important prognostic marker of ILD progression, but also mortality. Very, very strong. And it's typically, FVC is what we typically use as our endpoint in clinical trial for ILD and IPF. But as you know, spirometry is a forced expiratory maneuver, and these patients, because their disease, the lifespan of their disease is about 5 to 7 years, they progress fairly quickly, and it becomes increasingly difficult for our patients to perform spirometry. They also really hate it. I don't know that anybody likes to do spirometry, but our patients with ILD, IPF particularly hate doing it. So last year when I presented this, I showed that actually if we look cross-sectionally, if we do spectral oscillometry and we do spirometry within the same day, we can show that FVC and FEV1 correlate very strongly with oscillometry measure. And our strongest correlation was with the area under the reactance curve AX. And we kind of looked at it in men and women, and it was a pretty strong correlation. And so we're taking our same patients that we've already tested, and we're testing them longitudinally every time they come to the visit, to their clinic visit. And what we wanted to know is, can oscillometry measurement detect disease progression over time? And do they track a change in FVC over time as well? I chose here specifically to look at FVC again, because it's one of our most important clinical marker of disease progression in ILD. So this was an observational longitudinal study, and we took all our patients, well, as many patients who consented, or adult patients who come to our ILD clinic in our tertiary care clinic at the McGill University Health Center sites. We have 2. And what's really important is we took all patients with any diagnosis of ILD. So they include many diagnostic subtypes. It could be idiopathic pulmonary fibrosis, it could be sarcoid, it could be occupational lung disease.
And that's a good and bad because it does increase heterogeneity in our population, but at the same time, it's better for kind of reproducibility because we have a broad patient population. They were included if they were booked for spirometry on the same day as their clinic visit. And they had to have at least 2 oscillometries done within at least 6 months apart. We used all our testing using the TremorFlow machine. We used summary statistics to describe our cohort. We compared within patient change in oscillometry measures and spirometry measure using paired t-test for those measures that were parametric, but we used a Wilcoxon sign rank test for paired measures in variables that were shown to be non-parametric. So this is our population. We ended up with 43 individuals who had at least 2 measurements at least 6 months apart. Our patients were on average 61 years of age. We had a very good balance of male and female patients. And we have a fairly diverse patient population in terms of the self-identified race and ethnicity, with 65% of our patients were Caucasian white, and then the rest were 21% Black, some Asian. Unfortunately, we did not have any Indigenous patient in this repeated measure study. And we had a pretty broad range of diagnosis, which really represented what we see in our ILD clinic. What's important to note is that some of these diagnoses also have concomitant airways disease, which I think is important when we look at oscillometry. So this is the lung function that we had at baseline and then follow-up, and this is the result of the paired test that we did, the paired statistical analysis. So our patients lost a little bit of FVC, but not that much. It was not significant here. In terms of absolute value, about 40 milliliters over median of a year, so not that much. They lost a little bit of diffusing capacity, but not that much, not statistically significant. And when we look at our oscillometry measurements here, what really came out, so it was clear that the R5 minus R20 was non-parametric, and the AX was non-parametric. So we used our non-parametric statistical analysis here. And the strongest correlation that we had in our paired analysis really was a change in AX. And we use here the median because of non-parametric measurement. And the median AX actually increased from 10.8 to 13.1. And I'll show you kind of our individual patients and their trajectory. So again, we had a bit of a range. So some patients had fairly close repeated tests, and then some patients had a year and a half between their 2 tests. So over time, I kind of plotted individual patients, and here is kind of their baseline AX. This is the mean line here. So we had some patients that had very high AX. But here, if you look at the follow-up, we overall had more patients who were over the mean here, more patients that had very high AX values. And
We
so
also know the skills are different.
yes, that's correct. My scales are different. That's why it looks funny. Yes, I really tried to fix the scales, and then I was in a bit of a time crunch, so I didn't get to do it. I just came back from vacation yesterday, so I kind of did it on the beach. So I really tried to fix the scales, trust me. Okay. So, but yeah, so that's why it looks funny, but overall, you know, the mean AX was higher, and then more patients had a higher area under the reactance curve, which really is a measure of total respiratory system stiffness, which you would expect in patients with ILD and kind of disease of lung stiffness, that as they progress, their AX would increase over time. That makes sense. So I kind of plotted individual change in FVC for each patient and individual change in AX, and it got really messy. I didn't like that so much. There's a lot more variability in the FVC and a little bit less in their AX. Overall, more patients are going up. So then I plotted the difference in FVC over time and the difference in AX over time. And I'm not sure if it's better or worse, but what I thought was really interesting is that the values of FVC change over time were very scattered. So here's the difference. So everybody starts at 0 difference for their baseline. And then the second measurement, I'm kind of plotting who has a greater FVC and who has a lower FVC. And it's a bit mixed. Some patients actually improved, some patients got worse.
Are you treating?
This is in
patients?
leader.
Yeah, these patients are treated.
Yeah, for sure.
Okay, so.
Yes, we'll get to the question
Congratulations.
period, Ron.
You're a
We'll
good
get to the
doctor.
question period. We'll get to that in a minute. For sure, I'm treating these patients. These patients come to my clinic. Yeah, I can't not treat them. So then I will get to the question period. I have just a few more slides. So then I plotted the difference in their AX and the difference compared to the difference in their FVC over time. And I try to see, do they track? So if my patient FVC goes down, it means their disease is progressing. I would expect their total lung stiffness as measured by AX to go up. And it kind of works. Here you can see the Spearman correlation. Again, AX was non-parametric, was almost statistically significant. I mean, I think it's real. I think they do track. But I was really intrigued by some of these outliers here. Why is this person who has had no change in their forced vital capacity over time has such a dramatic increase in their AX over the duration of the study? So then I looked at that. And so I looked at these individual outliers, okay? Because I knew you were going to ask me this question. So this one is a 61-year-old woman who has a diagnosis of hypersensitivity pneumonitis, which was not fibrotic. It was an inflammatory type of hypersensitivity pneumonitis. And as I mentioned, some of these diseases can have airways disease, and that's one of them. The FEV1 is slightly dropped. She was a bigger woman, and her R5 increase her resistance of the airway at 5 Hertz increased from 6.7 to 7.3. So I think that's a little bit of what we're seeing. I think that could also impact your total respiratory system stiffness. So then this person also tracks, right? Because then the FVC is actually quite low. The FVC dropped by 670 milliliter. And then the AX really also improved quite a lot. So I think that makes sense. It's less of an outlier. And then this person, I was also intrigued by. This person had almost no change in FVC, but a significant improvement in their AX. And this was a patient who I think actually, got better when I treated them. I treated their myositis-related ILD, which was not really fibrotic. It was more inflammatory, more like an organizing pneumonia that gets better with treatment. And their resistance also actually improved. So I think that's what we're seeing.
Did she gain weight with steroids?
Sorry, did I?
Gain weight?
Did the person gain weight with steroids? I don't know. I looked at the BMI. I can't remember what it showed. Maybe there's a contribution to that. And then finally, I looked at this person, a man, a 78-year-old man with unclassifiable disease who had a pretty good drop in FVC, 110 milliliter. That's significant progression in their disease. And the airway resistance there, R5, improved a little bit. So I think that's what we're seeing. Again, because it looks at the total respiratory system stiffness, then it's a mixed bag. You don't just see the actual parenchymal stiffness. You really see the whole respiratory system. I did a regression of AX to try to see if there were baseline variables that were associated with a change in AX over time. This is a linear regression. It's a problem because AX is non-parametric, but I also did a non-parametric regression and it got a bit complicated. I have to kind of spend more time on it. But just looking at that, there were no significant baseline variables that are associated with more change in AX over time. It could be that my population is a little bit heterogeneous. It could be that my population is small. When we look at FVC change over time, age, male sex, and the diagnosis usually typically really impact are very strongly associated with the FVC change. So I have to look in each diagnostic category to see if that makes a difference or not. But I don't really have enough patients to do that yet.
Just point of clarification.
Yes.
When you say they have ILD, And those various categories, was that confirmed how? With
By
biopsy or
CT
CT?
scan, some of
CT.
them had a biopsy, but the CT scan.
Mostly CT.
Yeah, so a CT scan is the gold standard for identification of ILD and typically for the diagnosis. All of my patients who get enrolled in this have to have a CT scan diagnosed ILD.
Okay, well, yeah, that's important.
And a multidisciplinary diagnosis and yeah. So in summary, we can do longitudinal oscillometry measure and they do change with patients with ILD. AX is more strongly associated with disease, what I call disease progression or disease change. And that they do track with change in FVC, but from what I've done so far in my preliminary analysis, no clear baseline variables were associated with AX change over time. So, okay, which were your questions? Go ahead. Hit me.
We'll take prerogative and ask.
Please, yes.
Well, actually, we'll have comments. First one is that, when I was running the load function lab at National Jewish. Beginning
We're good.
Beginning-
Good with the camera. Good.
the director. Okay. My agent's gonna be talking to you. I was struck with how much airways disease was in ILD patients. This was the Schwartz-King cohort back in the early days, and was rare to actually see somebody who only had restrictive disease. So airways disease is very common, and the explanation is obvious when you look at the pathology. You see the airways are involved in almost every case. The other comment I'd make is that there was at the Aspen Lung Conference this year, which is on ILD, there was a presentation by Kevin Brown and company. They did a big survey of physicians. And physicians use FEC, DLCO, and a distant third was HRCT to look at progression. And you're showing that oscillometry is superior to FEC. So that's a really great thing for the clinicians in the audience. So questions, do we have any online first?
Other comment, congratulations, Deborah.
Yeah, this is
This
great.
is a first as far as I know. Very, very exciting if it's reproducible. As your numbers get bigger, you've got something very important to share with the world.
I totally concur with that. So good job. And I'm sure it's because you're a fabulous clinician in treating cases, in spite of some comments from you. Any other comments from? Yeah. Jay.
It seems to me, a very good talk, by the way. It seems to me the heterogeneity cohort here is really important because I suspect the key classifications you could put your groups into is, do they have an inflammatory type process or do they have a remodeling of the protein structure tissue type process? Because if they have an inflammatory process, they're more likely to get gunk in the airways and things that predispose to transient recruitment as they take a breath, as opposed to actually having a stiffer bungee cord in there, just harder to stretch. And that could explain, I think, the difference between, or sometimes the dissociation between FVC and AX. Because AX, again, this came up before, is the sort of, if you have a lung that's recruitable or derecruitable, it's the open state of the lung at steady state. When you do FVC, you take a great big breath, you open everything up, and then you blast out. And you're looking at a very non-steady state situation of the lung. So it could be, in fact, that the combination of oscillometry and spirometry together is important for distinguishing these two things. You don't want to throw it, you want to use them both at once.
Yeah, I mean, I think that makes a lot of sense. I think that's a really good point. For our cross-sectional study, we had about 100 patients, 101 or something like that, and we separated them into those with fibrotic disease on scan and those with non-fibrotic disease. And we were able to show some differences in their oscillometry measurements between the fibrotic and non-fibrotic. I don't really have enough patients really to look at that for this repeated measure study. But we have that. We have everybody has a scan, and we get the radiologist to review it. We had my pulmonary fellow look at all the scans and classify them fibrotic, non-fibrotic. So we have that, and we can look at that. And I think that's really critical that we're not gonna. This is not a competition between what's better. Is it oscillometry or is it spirometry? We're really looking at an additional tool to better assess disease progression in these patients for clinic, but also for clinical trial, I think.
I think with the very this population, I think it'd probably be important that we look at other airway disease. So I would look at the FVC, but also the RV-to-TLC ratio, because I think that could tell you a lot more. Because what I noticed was that there wasn't actually change. In fact, there was no change in terms of the FVC but in the 2 time points. I mean, which is great.
There's not much, no, 40 mils on average. But again, there's a variability. Some had a very high change and some had some improvement. Yeah,
They're under treatment and it's a short period of time.
that's right. Yeah, it's a good point. Thank you.
Yeah, hi. I'm trying to understand why you didn't see other parameters also change, given, I think you commented about airway involvement, small airway involvement, lung disease. And you didn't show that data about the R5-19, even just the R5, and also the parameters you might expect to go along with X, like X5 and resonant frequency. I mean, did those change at all, or what? Why just? I'm learning about oscillometry. Why X?
Well, so when I compared, I did a paired comparison. The X5 did not come out as a significant change in my population and paired. So between patient to patient, when I'm comparing each patient to themselves, X5 did not change significantly at all. The R5 minus R20 did change a little bit. It was kind of borderline statistical significance. But for the focus of this, it makes more sense to look at AX in terms of the physiology of the disease than to look at the so the difference in resistance between 5 and 20 hertz. So that's why I focus on that for those 10 minutes of my talk. FRES did not significantly change within patient over time. Again, it could be because the disease is heterogeneous. But airway disease, although it's a confounding factor in a lot of patients with ILD, the predominant problem really is a restrictive impairment. And if you look at, FEV1 over FVC or V2 TLC ratio, it's not very abnormal in these patients with ILD. But if you look at pathology, yeah, they may have inflammation in their airways, but it's not the predominant physiological problem. So that's why I concentrate on AX. But I think your point is well taken, that we have to look at all measures. I only had 10 minutes. So.
Mathematically, shouldn't the AX and the rhythm frequency also change, though, if you're calculating the area under the curve? It should change a little bit. I mean, maybe you can't pick it up.
Yes, for sure. Absolutely. Absolutely.
So one suggestion, you were struggling with your AX and trying to get it to fit into the regressions. If you maybe do a log transform.
I did that. But the problem with that is that I lose data because you can't log transform negative data. I mean, that you lose them.
You can add a constant to it.
I did that also. Okay. I did all those things, and adding a constant and then log transform did not normalize my variable. So it remained not normally distributed. So that didn't help me. And then when I log transform, I lost 14 observations that had negative AX. So I didn't want to do that. So I just think I had to get a statistician to help me with non-parametric regression. Yeah, it's easy.
Are you volunteering, Charlie?
No, you use it with a pencil and paper. That's what I like about non-parametric. You don't need a computer. It's just breaking.
That's right.
Maybe you've got two populations of people, some people getting worse and some people not getting as worse or staying stable versus noise, the AX divergent.
Yeah. Thank you.
Okay, well, thanks very much. Okay, our next contestant is online. Dr. Furukawa from Nara Medical University in Japan. So we're gonna have to have some help because I can't do this.
Hello.
Okay, I see. Shin, welcome.
Hi.
So you
Hello.
can hear us. If you want to start sharing your screen and introduce yourself, we're looking forward to your talk. What time is it in Japan right now?
Early morning.
30 in the
But
morning.
4 a.m.
Well, thank you very, very
Japan.
much. You look amazing. The audience is very
I'm
impressed.
sleepy. Share the PowerPoint. Where?
Good, and presentation mode, and we're there.
Sorry.
Well, we can see it, so good.
Yeah.
Okay.
Perfect. Thank you. You're on. The podium is yours.
Okay. Just a moment.
We can see the slides if that's the concern.
Okay. I will begin. Analysis of the phase-shifted post-association technique parameters as an auxiliary diagnosis for idiopathic pulmonary fibrosis, usual interstitial pneumonia. Background. Interstitial pneumonia is a destructive disease characterized by fine cracks on auscultation. Fine cracks are thought to be caused by the sudden opening of the small airway and alveoli of the lungs from the abnormally closed state. Fine cracks are generally heard in the second half of inspiration. However, the onset timing of fine cracks is earlier in interstitial pneumonia with honeycombing than in those without. It is expected that the respiratory mechanical properties change during inspiration. We hypothesized that FOT can differentiate the presence or absence of honeycombing. The FOT is a non-invasive test that can be performed with resting breathing, allowing repeated measurement and assessment over time. A summary of the FOT parameters is shown in the figure. We focused on parameter XRS. Method. We consecutively picked up 107 patients with interstitial pneumonia who underwent detailed respiratory function tests at our hospital from May 2013 to May 2022, excluding patients with CPFE, PPFE, or lung cancer complications. This is the FOT waveform data. Blue is volume, red is flow, and green is pressure. First, the conventional FOT parameters are measured, and then
FOD parameters are measured at 3 different time phases as shown in the figure. In a simplified, easy to understand manner, the figure is as follows. In the past, 40 parameters were measured on inspiration and expression. But this time, in addition, they were divided into low and high blank volume positions, as shown in the figure. The time-shifted parameters are calculated as the average of the 3 locations. There are 72 patients with not honeycombing and 35 with honeycombing. There were significant differences in age and BMI, with higher age and lower BMI in honeycombing. The table below describes what disease a patient are present in honeycombing and not honeycombing. Result of pulmonary function test, no significant differences in VC or TLC. No differences in FEV1 or FEV1 by FVC ratio. DLCO and DLCO by VA are smaller in honeycombing with significant differences. Results of pulmonary function. So the result of conventional FOT parameter R5 on expression is lower in honeycombing compared to not honeycombing, and there is a significant difference. X5 on inspiration, X5 on expression, and the difference between two is also not significant. Time-shifted FOT parameters, there were no significant differences in R5 and R20 at low and high lung volumes. But delta X5, which is the difference between the two, was significantly higher in the honeycombing, although there were no significant differences for X5 at low and high lung volumes. R5 and the X5 were compared with conventional and time-shifted FOT parameters. Honeycombing have a high X5 value at the low lung volume level and a more negative X5 value at the high lung volume level. The lungs are considered to be stiffest at the high lung volume level. On the other hand, there was little difference between honeycombing and not honeycombing in inspiration X5 and expiration X5. This suggests that there might be differences in mechanical properties between honeycombing and not honeycombing. The right figure shows that the respiratory resistance is lower during inspiration than during expiration. In addition, R5 tends to be lower in honeycombing. This is presumably due to the traction bronchodilatation characteristics of honeycombing, which also result in lower respiratory resistance. The following diagram illustrates the main parameters. expiratory R5 was significantly lower in honeycombing. Delta X5 was significantly different. Multivariate analysis showed a significant difference between age and Delta X5 with and without honeycombing. In honeycombing and not honeycombing, differences in 5 Hz reactance were found at low and high lung volume, as reactance is mainly an indicator of lung stiffness and airflow. It is expected that the mechanical properties of honeycombing change between high and low lung volume. In honeycomb lung, we would expect collapsed bronchi and alveoli to expand in early inspiration. Time-shifted parameter, Delta X5, rather than the conventional FOD parameter, may be more diagnostic of honeycombing, a key feature of IPFUIP. So,
Thanks. So I'm going to ask the first question, and I'm not sure I understood what time shift it is, except that I think it's the measurements made at peak volume as opposed to averaged over inspiratory and expiratory. Is that correction? Did I get that right?
sorry.
Did you understand my question?
Sorry. Pardon?
So when you call it time shifted, are you talking about the fact that you're measuring right at the peaks of lung volume as opposed to averaging it over the phase?
Peaks and the troughs.
I think what he's going from halfway up top and down again. So he's just shifted it over a little bit. He's capturing a high lung volume, which encompasses the top of the volume. And then the other component, which would be the equivalent of our end expiratory, he bracketed the lower part of the tidal volume. And that's what he calls the low
So he's
volume.
really looking at the extremes of lung volume.
But he's averaging the signal over that 50%. So instead of dividing it the way we do, where it's inspiration only, expiration only, he's saying, well, what's the top half of the lung volume and what's the bottom half of the lung volume average?
Okay, so that wasn't clear, or I'm just a little slow.
Yeah, no, I think that's what it is.
Okay.
Correct us if we're wrong.
Did we get that right?
Yes.
Hopefully. Is there any different? So most people say that reactance is stiffness of the lung, and I don't think the evidence for that is real strong, but it is really related to lung volume. We certainly see that in the animals. We know that's the case. So I guess my question is, have you measured lung volume in these two groups of patients, and are the lung volumes smaller in the honeycomb patients than the non-honeycombed patients? Do you know? Does he have the FVC?
Yeah, and he showed TLC data too. Right?
Was there TLC data?
TLC data.
Was similar? Okay. Yeah, well then it may be the working volume that they're breathing at. Okay, any other questions?
Jules
Any
Allen.
questions on
Jules
those?
Allen has a question. Julian Allen.
Yes, hi. Hi,
Hello.
Charlie. Thank you, Dr. Furutaka, for a very interesting talk. You know, in one of your slides, you showed crackles as being an inspiratory sound, but there are certain pediatric lung diseases, interstitial lung diseases. I'm not sure if this happens in adults, where you actually can hear expiratory crackles. Neuroendocrine hyperplasia of infancy is one of those. And I'm wondering if you have any kind of a model of that. Jeff Fredberg once wrote a very nice paper with a possible physiologic explanation for that. But you know, in medical school, we're always taught that crackles are an inspiratory sound.
Yeah.
And yet, the first year that I heard this, I didn't believe my ears. But the more that I saw patients with knee high, the more I heard that sound. And I wonder if you hear that in adult patients, and whether it has any relationship to what you're talking about, Dr. Furutaka.
So, sorry. My point that if the fine crackles is having the first half of inspiration in the honeycombing, then the respiratory mechanics are changing between the first and the second half of inspiration. That's all.
Yeah.
Sorry.
Okay, thank you.
Thank you. Any other questions?
So congratulations on the study, and I really love the data, partly because it actually very much confirms what we have found in our population. So what we looked at was we used the infrabreath measurements of zero flow. So reactants at end inspiration, reactants at end expiration. And what we found and this is a group of pure IPF population. So not a heterogeneous group, but a pure population of IPF, where we found that the XEI, the reactants at end inspiration, so at the highest lung volume, which is what you're doing, but at zero flow. And so it's got that one time point. And what we found that it was highly correlated with disease severity as measured by not just the FEC, but also by that GAP score, which is the gender, age, and physiology score. And that it was also highly correlated with CT parameters of severity. And so I think the metric that you're describing is perhaps a more readily obtainable metric than the detailed analysis that's needed for the infograph. And so I think this is actually fabulous data.
Great. There you go. Jason.
Yeah, I was just going to follow up on that. I mean, what it suggests to me is that the curvilinearity of the pressure volume relation is more pronounced in the honeycombing versus the non-honeycombing. You know, we're all familiar with that curve. The lung gets stiffer. It just gets stiffer faster as you go up in volume, is what it says. If you were to do a conventional PV analysis with an esophageal balloon, instead of the curve going up this, it would sort of.
And that's actually what we would see in our patients. And we talked about biopsying the PV curve. So when we saw high static elastic recoil at or near TLC, that was almost pathognomonic for ILDs of this type.
And so you would expect it to correlate with severity just as treatment.
Yeah. In fact, I like to call oscillometry the point of care esophageal balloon. Doesn't mean much to most people, but you get the, you know what I mean.
But it also suggests that measuring oscillatory mechanics at different lung volumes, just as Shen's been doing, is really going to push us forward in understanding, particularly in ILD, where the lung is actually getting stiff.
Yeah.
All right. Well, thanks so much. That was great.
Thank you.
Our next contestant is Roger Pang from McGill. And Roger, why aren't you in the room? Well, what's your story here? Why are you in China?
Come on, Roger, speak up.
What's the
Hello.
story?
Good
Hello.
afternoon. I'm on vacation right now.
Oh.
Ask him where.
And Roger, where are you on vacation?
I'm in China right now.
Oh, okay. So I guess that's a good excuse not to be here.
What time is it, Roger?
It's around 3:30 a.m. So
Yeah.
exactly 12 hours.
Yeah, it's getting a little earlier there. Good on you, Roger. So you get bonus points for showing it. Today you're going to be talking about oscillometry, spirometry, and with a particular brand of COPD, and that's the alpha-1 antitrypsin genotype. So take it away. I'll let you share. There you go.
Perfect. Thank you for the introduction. Can you all see my slides?
Yes.
Perfect. So, yes, my name is Roger, and I'm a medical student at McGill working with Dr. Dandran, and I'll be presenting my project on characterizing COPD using alpha-1 antitrypsin genotype, spirometry, and of course, oscillometry. Some of you may have seen this project before as I presented this data at the previous ATS 2 months ago. So as you're most likely familiar with, alpha-1 antitrypsin deficiency, or alpha-1 for short, is the most prominent genetic risk factor of COPD, and it is linked to decreased levels of plasma alpha-1 and defects in the serpin-1 gene. And it is likely underdiagnosed in our population, as screening for it is not common practice in the clinical setting. So gold guidelines were used to diagnose and grade COPD, and spectral oscillometry was also done to assess the mechanical properties of the respiratory system. And in fact, oscillometry parameters have previously been linked to measurements of ventilatory heterogeneity. For quantitative CT scans, or QCT, we looked at the low attenuation lung density less than minus 950 Hounsfield units. So the LAA ratio for short, which has previously been linked to degrees of emphysema, and upper lobes are usually primarily affected in smoking-related COPD, whereas the lower lobes are primarily affected in alpha-1 patients. So what exactly prompted us with this study? Well, in Dr. Dandran's clinic, there were 2 cases of homozygous ZZ serpin-1 genotype with pretty advanced COPD, but paradoxically, they had less abnormal oscillometry measurements. So our hypothesis is that alpha-1 patients may have decreased mechanical heterogeneity and therefore decreased ventilatory heterogeneity in comparison to usual smoking-related COPD. And that's because of the blood-borne etiology of alpha-1. So we did a retrospective chart review between 2013 and 2023 at Dr. Dandran's clinic in the West Island of Montreal, and we included COPD patients that were screened for alpha-1. We collected CAT scores, spirometry, spectral oscillometries, parameters using the TremorFlow machine, and acquired DICOM CT scan files using Oscirix. So we followed local guidelines adapted from the ERS recommendations for the screening of alpha-1. So first, COPD patients were offered plasma alpha-1 measurements, and if their levels were above the 1.15 grams per liter threshold, they were classified in the usual COPD category. If their levels were below the 1.15 grams per liter threshold, PCR genotyping was subsequently done for the S or Z serpin-1 alleles. So patients with the MM genotypes were grouped in the non-alpha-1 category, whereas patients with at least one S or Z allele were grouped in the alpha-1 category. For percent predicted values, we relied on EC-SC equations for spirometry metrics, whereas we use Berger's equation for oscillometry parameters. For QCT parameters, we use the 3D slicer program and the parenchyma analysis tool. And we relied on both JASP and Python for our statistical analysis. And we investigated differences between these groups using Mann-Whitney U-test or chi-square test as appropriate. And because of the exploratory nature of the study, we did not adjust for any repeated measurements. So in total, 353 COPD patients were included. All patients were screened for alpha-1 and underwent both spirometry and oscillometry. QCT data was available for 274 patients out of the total of 353. And we can see that 31 of these patients were diagnosed with alpha-1 through the S or Z allele, and 322 were classified in the non-alpha-1 category. And there were no significant differences in both age and sex between the groups. And of course, by definition, as you would expect, the plasma alpha-1 levels were lower in the alpha-1 group. So alpha-1 patients had a median CAT score of around 19, whereas the CAT score was around 16 in the non-alpha-1 group. So this suggests that alpha-1 patients were more symptomatic than non-alpha-1 patients. So both absolute and percent predicted spirometry metrics. So we looked at FEV1, FVC, and the ratio between FEV1 and FVC did not differ between the two groups. And for oscillometry parameters, so all spectral oscillometry metrics trended towards lesser perturbance in the alpha-1 group. And notably, 3 predicted oscillometry metrics, so the reactance at 5 Hertz, the resonant frequency, and the area over the reactance curve differed between the two groups significantly. So we can see the XI had a p-value of 0.031, FRES and AX also had significance between the groups. And we can see here visually that patients with either an S or Z allele trended towards less abnormal oscillation mechanics. So QCT data revealed that the LAA ratio was significantly lower in the alpha-1 group. So we had a median ratio of 1.06 in the non-alpha-1 group and a ratio of 0.69 in the alpha-1 group. And we also did the correlation heat map with Spearman's rho and uncorrected p-values. And as expected, the spectral oscillometry results correlated quite nicely with the spirometry metrics. And interesting, there is very weak, very faint correlation between the LAA ratio and some of the spectral oscillometry parameters. And I think that may warrant some investigation in the future. So all in all, 9% of the included COPD patients were carriers of at least one S or Z SERPINA1 allele and therefore diagnosed with alpha-1. The CAT score revealed a greater symptomatic burden amongst the alpha-1 patients, and while spirometry metrics did not differ between the groups, 3% predicted oscillometry parameters, so X5, FRES, and AX differed between the groups and were lesser perturbed in the alpha-1 group. Our QCT data also confirmed the lower lobe zone predominance in the alpha-1 patients and in comparison to the usual COPD cases. However, we still speculate the underlying mechanism of the observed lesser mechanical heterogeneity through our oscillometry results. And in alpha-1 related COPD, we speculate that perhaps parenchymal textual analysis or the median curvature of isotopes could provide further answers. So oops, I'm sorry. So for a limitation, our study may have ignored some of the rare alpha-1 alleles, as we only identified the S or Z SERPINA1 alleles, and we speculate that many patients that had low plasma alpha-1 levels may in fact have rarer alleles of the SERPINA1 allele gene, and were not detected in our project. And finally, I would like to thank my supervisory team members and colleagues, as well as our supporters, and I'm open to any questions. Thank you.
Thanks, Roger, and our deepest condolences for working with Ron.
Okay.
No, wait a minute. No, I'm gonna ask the first question. You put me in charge. This is what's going on. Do these patients smoke, these folks with the alpha-1? They're-
No.
Let Roger answer.
Yeah, let's Roger. Roger?
Well, from I'll have to go back at the data set. We did collect the pack years for most of these patients, but I believe that most of them, in fact, did not smoke, if I
Yeah.
remember correctly. And
If they want to
also
stay in the practice, they have to become non-smokers, but every patient has greater than 10 pack years to their credit.
Ah, okay. I wondered about that. Because it's my understanding that the histology of these patients is much more panaceter as opposed to central lobular. Okay. And that may be part of the differences that you see.
I'm conveying a question from Julian Allen. He
Yeah.
wanted, Jules in Philadelphia, Roger, wants to know whether you are staying up or just getting up to give the presentation.
Or both.
Jules, go ahead.
I'm staying up. I'm still a bit jet lagged, so it's
Oh,
my
so it's easier.
circadian cycle is still partly in Montreal.
So there you go.
This is a fascinating talk, and you're saying that they're more symptomatic, but they have less physiologic abnormalities. That's a fascinating observation. What's your speculation about that?
Well, our speculation is that alpha-1 patients have more even distribution in emphysema, and that's what we're observing with the oscillometry results. So they're not able to detect specifically the amount of emphysema. It instead detects the distribution of the lungs. So it's AX and I think FDR are usually higher when there's more heterogeneity.
Mm-hmm. Interesting.
They might also have less airway pathology, which triggers certain kinds of receptors too.
Mm-hmm.
Roger, great talk. Two questions from me. One is I noted that you used the Berger reference equation, and I'm interested to hear the rationale for that. The second question is, do any of these patients have bronchiectasis?
Can you just repeat the first question? It cut off a bit.
Your choice of reference.
Yes.
Why did you use
So
Berger? I think is the question.
So if I remember correctly, there was a percentage predicted normative equations that came out from one of the bigger study, and that's what we're relying on. And we only had the only parameters we had were the age, sex, and weight and height. And I think that's just the convenient way of going for a study. Can Dr. Dandran confirm?
Yeah, Roger, you can be honest. You can simply say it's because what my boss told me to do that. I usually because Ken is my friend. So we seriously wanted to have a North American based population, and although Zolies or Ellies, whatever you want to name them, are widely used, they have this issue that they were gathered in different centers using different devices, some of which are no longer on the market. So although we can be criticized for using an iOS device to use it as predicted on a forced oscillation device, I'll take that, arguing that the iOS performs reasonably well at low impedances. So to generate normative data, I'm comfortable with it. It's imperfect, but oscillometry at this point is the perfect tool.
So here you go, Roger. We can blame Ron on that one. Second question.
Yeah, can I just follow up with that before you answer the second question? Because the Berger equations actually correct for BMI and not height and weight. So what is the, what is your BMI like spread in your population?
It's like any COPD population. We have a few obese patients, but the sicker they get, the lower the BMI goes.
Any other questions? Fantastic. Thanks, Roger. Really good job. Now you can go to bed.
Bronchiectasis was the question.
Oh, the bronchiectasis.
Wait, so Roger, was there any bronchiectasis in the patients?
I think I'll also have to defer this question to Dr. Dandran because I'm not as familiar with the patient population.
Absolutely. In fact, in my practice, usual COPD has a background bronchiectasis rate of about 20% or under. However, if you carry either an S or a Z, that rises up to 80%. And I presented that as a poster. In fact, I'm wanting to get one of my students at some point in time to follow up on that because I think that would be important to get into the literature if it's true. It's debatable at this point. It's a point of controversy, but I believe it's in fact changed my practice. I give longer courses of antibiotics if you carry an S or a 1 for an action plan, because from the get-go, I know they have a higher background rate of bronchiectasis.
So that goes along with the lower resistance in that group.
It might.
So that's traction bronchiectasis.
Yeah, are you calling it bronchiosis or bronchiectasis?
Bronchiectasis. It's the larger areas you see it.
And they're thickened?
Yeah, no, they have signet ring formation, they have tram tracks, the whole kit and caboodle.
So they look like mice.
But that's traction.
Right, that this population would have like less heterogeneous mix.
Well, if the blood-borne diathesis, both of us in the picture here, come on over. If the blood-borne diathesis is bathing all of the lung tissue equally, then you would think that there would be less protection and so more net breakdown in the lung, more evenly distributed. That's the hypothesis anyway. The data is consistent with that hypothesis. There may be another explanation, and I'm looking forward to see if somebody else can reproduce this data in somebody else's practice to begin with.
But Ron, one thing that occurs to me is if this bronchiectasis is traction bronchiectasis you're talking about.
No, traction bronchiectasis will be in fibrotic lung disease.
Okay, so this.
So the alpha-1 is interesting enough, even without the emphysema, is associated with increased background bronchiectasis. They get the liver disease, they get bronchiectasis, they get paniculitis, which is inflammation of the soft tissues, typically of the shins, as well as emphysema. So it's within the alpha-1 diathesis.
Okay, I guess it was a naive question. I just wondered if that was signaling that there's more stiffness in the parenchyma, real actual intrinsic stiffness, which might explain why AX.
Yeah, I don't know, because the traction bronchiectasis we see, and correct me if I'm wrong, Deborah, if you're still here, it's really more what we see in fibrotic lung world, which ultimately, that lousy disease. In terms of the symptom burden, I think a lot of it's, in fact, they have an ongoing inflammatory response, these people, especially the ones with the Z allele, because these pleated Z cells are not released from the endoplasmic reticulum, and they get something called ER stress, which we clinicians know full and well what that is, but this has nothing to do with our working conditions. This is simply that the endoplasmic reticulum is in this primed pro-inflammatory state. And so I think a lot of the background symptoms they have are due to that.
I see.
In Ireland, when they cut off the alpha-1 replacement therapy, a lot of the patients got really sick and symptomatic without changes in lung function or quantitative CT scanning. And so there may actually be an anti-inflammatory effect to this therapy that makes them feel it.
Yeah.
Speculation.
Okay. So now we can move on to the last talk.
With your permission. Oh, so it is with great pleasure that I am introducing Charles Irving from the University of Vermont.
Good job, Roger.
And Charlie is up here at my request because of the study last year, the lead study, which you know that I'm a big fan of. It was that population-based study that showed that, yes, we may actually have an increased detection rate using oscillometry in a population-based study. And Charlie teased us by saying that the 4-year data has been collected but not yet looked at.
Well, sort of.
Okay.
I'm gonna.
And I was pushing Charlie to see if I could get him to accelerate the data analysis, since it's collected. How fast can you share it?
So,
Take it away, Charlie.
well, you're gonna have to put up the slides. You
Oh.
think I can do that? That's why
I have
hired you.
people for that, right?
Yeah.
Okay.
My
So
people didn't talk to your people. clearly.
get this up here and share the screen. Zoom, come back.
Okay, so some of you think you're gonna think this is kind of a stupid analysis, but I actually think it's kind of cool. And I'm gonna-
Power of Z. Here we go. This sounds like a real internet infomercial.
Yeah, well, it is. I'm on a tour right now, evangelizing oscillometry, so this is part of it.
Roger, I'm gonna make you disappear here, but good job, Roger. Thank you very much.
Now, the hard work of a study like this is getting the money together and actually studying 15,000 people. And that's why I'm presenting on behalf of the lead investigators, because they get the big credit. In terms of disclosures. Okay, I give up. What do I do here?
Just put the arrow on the keyboard or the mouse.
Yeah, well, that's what I'm doing. Oh. Now what?
Some people never.
Well, it's, there we go. See, I don't need you. Go away.
Here we go. See, arrow
I
right.
tried that.
Just try it harder.
Okay. IBM, give me a Mac. So the funding for this, I think, is actually one of the biggest achievements of putting all the money together for this. I have to figure out how they did it because it's pretty amazing. And then I'm funded through the NHLBI and our lung health cohort study. And none of the parties had anything to do with it. And then I'm on the scientific advisory board. Oh, there we go. Now, one of the things I've learned from many years of teaching and training physicians, case in point, physicians don't do change well. One of my colleagues down in Vermont spent years trying to get people to actually ask patients, do you smoke? And couldn't manage to do that very well. And it's experience of changing a struggle to unlearn. I like this paper. Changing clinical practice is a difficult process. And existing models mostly focus on barriers to learning and implementing new knowledge, but changing practice is even more difficult because we get habitualized to that. And it says that one of the reasons for this is how long it takes to get something changed in practice. And believe it or not, there was a study some years ago that said that the answer is 17 years. Now, since this, if you do the math, this oscillometry seminar has been going on for 10. So you have 7 more years before you're going to change it. In case you wanted to know. Now, I personally believe, now I'm going to get a little more serious, that oscillometry is in an existential crisis. And this happens when I try to explain this to my colleagues. Now, the first one happened last week. I'm doing a study with the Lung Health Corps, where 12 centers are going to do oscillometry, and I'm speaking to one of the site PIs who's very well-known COPD investigator, knows his physiology really well. And he says to me, I always wanted more about oscillate, but I don't understand it. So I sent him our link to our CME thing. Then I get the comment frequently, it's too complicated. And I'll show you why that is. Then the more sophisticated ones will say, what is reactance anyway? And why is it negative? And believe it or not, the last one is a true quote. What are these imaginary numbers, right? And that you can just watch you lose your audience when you get into that, all right? So we got to do better. So my goal in my last few years of my life are trying to simplify this a little bit more. Now, I've spent most of my career training people in physiology, training nurses to do spirometry, training some of the most elite pulmonary respirologists since I'm in Canada, in Denver for 18 years, and getting it through their heads about lung function per se is really hard, okay? So one approach is, you see these three handsome fellows at the prime of their life. So we did this CME thing for ERS that I'm really proud of, but as I got to thinking more about it, it's for kind of an elite audience, the really interested pulmonologist, as opposed to the burned out one. So we have to do better. And so the aim of the current analysis is to take the lead data and look at how well does impedance, just a single number impedance, relate to R and X, which the mathematicians in the room know, of course it does. What is its relation to symptoms and disease? And then as a teaser to you, Ron, what happens 4 years later? So why Z? And that's because if you show, this is probably Jason's masterpiece. I love showing this equation, sorry, Jason, and watch people's heads explode.
I must say that this equation due to Baylor Sugi, not me.
Okay, that's right. Throw Bela under the bus. Notice it's equation number 38 in a series.
Wait, Zoli's online with us now.
Yeah, Zoli's in part of the result. But you can simplify that to this, that basically impedance is related to R and X. So the lead study, just to remind you, is a big cohort study done in Austria, mostly in Vienna. And it's to look at comorbidities and other sorts of things, which is when they started it. And it's all been, the actual study and how it was done has been published. It's longitudinal, and I'll show you a little bit of that, observational, general population. It's randomized by registry, which is really important because of the making sure that it's truly represented. And then it was stratified, the recruitment was stratified by age and gender. And it's ages 6 to over 80, and there's more than, it's about 15,000 records. Questionnaires, and then the follow-ups every 4 years. And they're just into the first follow-up. This has all been published. We used the Resmond device, and we used pretty much standard stuff. And we used both Berger and Osterman. But for this analysis, probably doesn't matter too much, although I'll show you one area where it does. So this is the first data. This is from 8,000 folks. And this first group have no symptoms or disease. So these are the ones that we're in the process of developing normative equations for, which hopefully will get done. And I put red dots on the Z. So this is what we've already published, but we've added Z to it. And as expected, it starts to track quite nicely, particularly when you look at both R and X. So in 748 people with disease, it's worse, it's higher. If they have anything more than one symptom, it's higher. And it's starting to shift here once you start adding any kind of symptoms, showing as before the sensitivity. Now, this is a little trickier, and this is sort of saying if resistance is abnormal, X can or cannot be abnormal. And again, it tracks quite nicely with that, as you might guess. So it's one of the nice things about using Z or Z is that if one changes and the other doesn't, you don't have to worry about it because they're both in the, it's like a composite questionnaire that we use in patients. Now, the fly in the ointment is shown here, and that is that there's really good concordance with Z and R, not so much with X. So there's a big group of people that have abnormal X using the predictors we have, and that will change as we develop our own, that are not getting picked up with Z. And I think the reason is because there's an adaptation in R to that. So controlling this for lung volume is probably going to be pretty important, I would think. But in spite of that, things track pretty nicely. Now, this is the teaser for Iran. So this is 4 years later for 1,600 participants that were without symptoms or disease at the first time point. So, okay. Now at the 4 years later, this is the group, 385 who have one symptom, more than one symptom, and then 62 of them 4 years later have diagnosed disease. And so they have abnormal Z at time 1. So these are the folks that have abnormal spirometry, or in this case, oscillometry, and now 4 years later have diagnosed disease, okay? So it would appear, particularly when you start looking at greater than one symptom, that this is going to be predictive down the pike, at least in some people. Now, the summary of this is, again, maybe not that blindingly brilliant, but it is a composite. And so composite scores, as we know in clinical research, are really function well. I've shown you that a Z would be required, increases with symptoms in respiratory disease, and it appears to be at least a predictive to some extent of problems down the pike, okay? So that's nice. Now, the nice thing about this is impedance is dead easy to measure. You just look at the delta pressure over delta flow and you're done. It is not complicated and it tracks with more complicated measures. And when we explain to our colleagues what we're doing, this is a lot easier. And let me elaborate on that. First, it's going to be very easy to build a device that only measures Z. All you need is a pressure transducer and a forcing function of some sort, as we've already discussed. Okay, so in discussion with the engineers, and I'm sure the engineer, Bob over here in the corner, will tell me if I'm wrong, but it should be quite easy to build a device. From a clinical practice adaptation, and the presentation earlier this morning, I think, was right on the money with that. It's one number. It goes up when the lung gets bad. It's easy to explain. Put some forcing function in, the pressure is high, the lungs got a problem. Okay? And I think this could hold huge promise in overcoming the kinds of resistance that I've seen in my colleagues when I discuss oscillometry. Okay. If you want to think of it, it's sort of, but in fact, it's probably superior to peak flow. Peak flow was highly used a lot because you could build a simple device and measure it on the fly. And I think this is the same sort of thing. So I'd like to thank my colleagues, particularly Chara, who's been doing the analysis here. Questions?
That was a great talk. So, and it's interesting you brought up peak flow at the end. So one of the reasons we don't like peak flow is because it's highly variable.
Right.
But compared to an R or an X, what's the variability for this end?
Well, you can see it on the data. It's the same.
Oh.
Yeah, it's
the error bars look.
They're the same. So it's the variability is the same as we see with other measurements. So that's good, right? And it's not effort dependent. That's the big downfall of peak flow. And of course, it's picking up, just that one spot on the curve, whereas this is measuring all the data. Jason.
Yeah, Charlie. First of all, I'd like to point out that we're in Canada now, so they do know what Z means. In fact, I'm very pleased that I managed to get people when I went to Vermont to eventually call it Z, not Z. And they didn't even realize. The other thing is that, you know, I got to say that the hard thing about making any kind of oscillometry device is the forcing function and the transduction and the measurement of the pressure and flow. Once you've done that, what you calculate is simply a matter of some algorithm in a computer. So I'm not sure that makes much of a difference. But beside that, when you say Z as impedance, how exactly is the calculation made? You simply take the swings and the pressure and flow and divide one by the other?
You know, as I was thinking about giving this talk earlier in the day, I thought, you know, I don't actually know how the Resmond does it. And
Because what I thought it was the magnitude of impedance.
That's what I thought it was.
Square root of the square of the real and the square of the imaginary parts.
That's what I think it is too, but I'm going to have to talk to Pasquale.
Well, we do have two Novus reps here, so I don't know if they want to drop into the conversation. Are you guys still with us? I saw you over lunch, I thought. No? Okay. Sorry about that.
Zolli.
Zolli's up here, so yeah.
Maybe he can eliminate me. And Julian has.
Thank you. I am on the transition of getting asleep and getting up. By your talk, which was very nice, Charles. As always, it was very, very amusing, very provocative, and probably focus on the latter. So it appears that you want to get rid of the interpretation problems of R and X by combining back them into Z or Z, as you say. So I feel it's a sort of backyard way of arguing. Sorry for that. It was a very great talk.
Thank you very much. Coming from you, that means a lot to me. And I agree, it is sort of a backward. I've sort of backed back into the beginning, haven't I? And there's something nice about that, in some way. Julian.
Charlie, I love this concept. I think it's a great idea. The only problem is when you have people coming up to you in the ICU and have made mechanics measurements on their ventilators, and they know that resistance is pressure overflow, and you're telling them that impedance is pressure overflow. How do you explain the difference to them?
You don't. You just tell them it's the same. Don't worry about it. Ignore the man behind the screen, right?
Fair enough. Fair enough.
How's it going to change anything? I mean, so now to be serious a little bit, when we have a diagnostic test, we're interested in two things for sure. The clinician is, and then those of us in the room are interested in the third question. The first one, is it or is it not abnormal? Yes or no? We already had that discussion earlier. Second thing is, how bad is it? Okay. Third thing, does it get better with treatment? And then I guess I should have made this the fourth. A lot of people seem to care a whole lot about why. And yeah, we delude ourselves into thinking that if we know why, we'll have some epiphany and we'll decide that one treatment's better than the other or develop a new treatment. But in the end of the day, the average clinician, particularly when they're in the ED, as we heard this morning, with all chaos raining around, they only really care is it or is it not normal? How bad is it? And did it get better when I instigated the treatment? Because if it doesn't, I'm going to try a different kind of treatment. And if it isn't bad in the first place, I'm going to think about some other things. So I think it hits the mark on all of those, except light peak flow, or even FEV1 when you think about it. The FEV1 is down in my patient. I have no idea why. Without more information, I can't begin to tell you, other than it's down, and as long as it's done properly. Now here, we don't have to worry so much about whether it's done properly, because you just sit there breathing. There's no gymnastic. So that's why I think this is appealing.
So since it's the last talk and we have time, so can you answer the first two questions? So do we agree what's normal versus abnormal? Your thoughts about Z-score what percent prediction?
Yeah, so
Do we have, though, the second question that you
Yeah.
asked, do we have a grading system like gold for severity?
right. The answer to the first is, as we've discussed already, the normative equations are really problematic. Fortunately, in this group, we have, what is it, 6,000, 7,000 records of people without disease, without symptoms, that we can now generate normative equations. We've already published them for children, for the children. We're working on the manuscript for adults. So that will get solved. And you can see it in the records with the odds ratio of people without symptoms, without disease, they're not at 0. Okay. And that's the difference between, as we've seen some of the other studies too, that we're not getting data close to the normative values. So that we will have. But the problem is it's a Caucasian population in Europe. Okay. So for in the United States, for instance, we still need to see if that's also true or applicable in Blacks and Hispanics. Your second question, which I've now forgotten.
The severity, the scale, like how bad?
Oh, yeah, some sort of scale. So the way I've always done scales, certainly when I've done semi-quantitative histology, is to look at what's normal, what's really bad, and then just split the difference into quartiles or whatever, tertiles, depending on your proclivities. And that's a pretty straightforward thing. They're artificial. I mean, the gold standards, we've talked about gold 0, gold 1, and that whole argument. But and I've never found, when I was reading lung functions every day for 18 years in some of the worst patients in the United States, I never really, it didn't seem to me that mattered much if they were kind of mild or moderate. What kind of matters is, are they abnormal and are they really bad? So we know that a patient with COPD who has FEV1 below a liter is going to be dead in 6 months, half of them, roughly, at least back then. So I think we kind of don't need all these scales as much as some people think we do. I'm not sure where it gets us because it's too arbitrary. But that's just my opinion. I'd be interested in the clinicians in the room, what their thoughts about that.
So one more question.
Sure.
So let's say now you have an oscillometry in front of you, a report that you're interpreting,
Yeah.
and it's a clinical practice.
Yeah.
How would you interpret, how you write it? So let's say it's spirometry. Those results are consistent with obstructive pattern, for example, and the severity, it is like this. So for oscillometry, how you write the report for a clinician?
With great care. Because I'm a physiologist and words matter.
Mm-hmm.
I think that's where we get working groups together. I think one of the things we need is, and we saw an example of that today, where presentation where we got into the weeds about talking about individual patients, because we can sit here and talk about global groups. But in the end of the day, the clinician cares about their patient that day and how am I going to interpret this? And I think that needs some careful thought. I mean, I've tried to do it when we did the CME thing, but it was once over lightly and it needs a lot more work. But yeah, you're right. We need to develop that. Jason.
Charlie, maybe I could say this at the end of the day. I just want to build on concept that you've raised. Let me present a vision, which is eventually, through computerization and data capture, every patient in the country who has any kind of lung function and follows through a course and gets diagnosed and gets treated, gets captured on some large database. Now, in the age of machine learning, what's going to happen then is that some machine learning algorithm, a deep net or something like that, is going to go straight from the raw data capture from that patient to the therapy. Everything else in the middle is going to be opaque to the user because none of it matters.
Yeah.
I presume what matters to the clinician is that you can give them a treatment and you can tell them their prognosis. So this is going to take, there's a lot of practical and political problems that have to be overcome before that happens. And it may take a long time. But I just see that eventually, inevitably, with the way it's gonna go. And, you know, us lab rats who like to understand why and what's going on, well, we'll get down in the weeds and worry about it. But I would imagine, and tell me if I'm wrong, I would imagine that most clinicians who want to treat their patients and make them get better and tell them what their prognosis, that's the way it's going.
Exactly. You said most clinicians, but what we care about, as we all know, at least this community here, is that we care about what's going
This is not a
inside.
representative group.
Yeah, the machine learning.
This is the lunatic fringe.
That's
Jason, we're a lot closer to that than you might imagine. Doing just that with raw pressure. So stay tuned.
That's interesting. Well, it's going to push people like me more onto the lunatic frame. You know, I'll probably be in straight jail.
So anyone has tried the deep learning on the curves, as we are doing now on the flow volume loop of the PFT?
Yeah.
Anyone did?
Well, there was a paper by Mark de Kramer, that was looking at automation of interpretation that caused quite a stir a couple of years ago now, probably about 5. And I've seen nothing else about it since. So I'm wondering what's happened in that space. But everything I get on the internet these days is AI. So we're going to see. Here we go.
There's a fair bit of action on ventilator waveforms because there's a lot more people on ventilators than there are oscillometer operators.
And there's
also the data sets are so huge. You know, you've got like 30,000 breaths a day. Right. That like manual overreading is impossible. So people are going at the low-hanging fruit first, like identifying the synchronous breaths that are profoundly different. And there's a broad spectrum of approaches here where some people are trying to identify features that can be quantified and features in the beginning. So there's like a manual step. Some people are making like a spectrogram and then using image recognition on the spectrograms. And as in all AI stuff, the hard part is the labeling. Kate and I have been talking about this in terms of like overreading quality versus not quality measurements. And the crux there is like getting the thousands of labeled good versus bads that you need.
I'm a big fan of Delphi techniques where you get a bunch of experts together and you get consensus on what they think it might be and use that as a means of doing it.
I was actually just thinking of that. It's knowing the ground truth stuff. And I'm wondering whether, in fact, eventually all the current disease classifications like asthma and COPD are just going to be useless. Somehow we're going to go directly to the end result. Because at the moment, things like asthma, we will struggle with what the hell is asthma, and it's got different phenotypes. It's a sort of a staging point we as humans need in order to classify people and then decide what you're going to do. But maybe you can just get rid of that eventually and go straight from the measurement to what you do.
It's already happening. It's back to the 1960s. It's obstructive lung disease, period. And then there are treatable traits.
Splitters and
so a lot of people are going that route in how they practice.
Yeah.
And our treatments of asthma and COPD are actually overlapping, including the application of biologics, very expensive therapies. So that's where things seem to be going.
Well, I have a more cynical view of that than
I think the key there too is not just limiting the AI to the oscillometry, but like, you know, Nydia was giving the regression models heart rate, for example.
Oh, you're putting it.
And as you're like feeding more and more of that data in there, the decision can become more and more fine-grained.
Yeah, you have a big hopper, all the information goes in and out comes therapy.
should be doable.
Yeah.
Oh, yeah. We'll have it next year.
Well, what are you doing here? You should be working on it.
I can be retired by next year.
All right. Aspirational.
I guess there are 2 things. I think working at a smaller, at the sort of smaller scale in terms of what to do over the next 5 to 10 years. I want to reiterate, I don't think that we should get too hung up on the reference values and cutoff values, as long as you state, this is what I had defined to be my normal, because it's going to change. It's going to change when you think about the world population. You know, 50% of the world population is not included in the reference values for anything.
Right.
And that will come. That will come, and that will mean that we will change our reference equations and what is considered to be normal. And then my last point is actually, I think that as physicians, as scientists, I think we need to be much more political, because one of the issues that has come up, of course, is the whole concept of privacy and data security. And just as an example, I work in lung transplant, and we had an international registry of all lung transplant centers where we actually all, sent in our data so that we had a good understanding of what our mortality and survival were like. And several years ago, laws were passed in Canada and in Europe that we weren't allowed to send this information. And so, all of a sudden, there's this huge data loss, and it has become, a major career, academic sort of activity of one of my colleagues in Canada to actually send the Canadian data. But the laws are such that we become the one point to actually enter all the Canadian data into a central registry that then goes to the international registry. So you think about all the individual, because you're all scientists, all the individual sharing agreements that have to come. And we do more and more AI, this whole concept of data security becomes more important. But I think what we need to advocate for is, why do we need to have data sharing? And well, at the same time, being able to.
It's a huge problem.
But huge problem.
And
I love the idea. Like, I love that.
his module, so he knows all about it for the state.
But these data were de-identified, were they?
Yes.
Yeah.
What's the problem? Why was the passed?
Oh,
So when I was in.
That's not my problem.
Task, I know.
Right,
So
but I think we need, as a field of scientists, as clinicians, I think we need to get much more political. In terms of advocating.
I violently agree with you. So when I was in Australia in the spring, talked to Shannon Simpson, and she had been really keen to get a hold of the lead data for the GLI oscillometry data. The window has closed. We're now going to have to get acts of Congress, and in my country, that's problematic to say the least. And we have, well, let's get political. I can get political. And so just getting that data from Austria into that data set, even though it's all part of Europe, et cetera, it sounds like it's going to be a nightmare. And I don't think any of my colleagues are going to be up for doing that. It's just too much.
I think also in where you are allowed to share the data, everyone has their own way of storing, their own nomenclature of things.
Oh yeah, I've run into that
Unifying
before.
that is a nightmare.
It's a nightmare. Yeah, the harmonization of the data sets is.
So if we want to
really
do
tough.
nice AI-based oscillometry interpretation, we should talk like now about how we're storing things.
So while Jason's view of the future is one that I embrace totally, some of the practical issues are gonna
that we're all going to be data gamblers.
But look, we still drive on different sides of the road in different countries, so maybe there's no hope.
All right. Well, thank you very much for really great conversation, and thank you, Ron, for putting this on, because we all get so much out of it.